Morning, everyone.
Morning.
If you can share the YouTube link, then I can send it to the people also. A lot of people were asking. Ashmita, room is open? Yeah, perfect. So we just wait for another few minutes because people are joining. There are nearly 100 people around. So Ash Ashmita, just get the madam into the room.
Yes, I sent her the request, but she's not accepting.
She has to be there before I start.
Yes, sir.
Yeah, there she is. So, Asmita, we start the program.
Yes, sir.
Good morning, everybody. It's indeed a great pleasure for me to have this first joint session of collaboration between Indian Federation of Neurorehabilitation and Mongolian Society of Neurorehabilitation. I have with me Professor Abhishek Srivastava, who is the Secretary of Indian Federation of Neurorehabilitation. Everybody knows him. And along with that, Professor Mandasir. Professor Mandasir, if you could put on your video, people would like to say hello to you. She is the head of Mongolian National Society for Neurorehabilitation. She has been bestowed by many awards in Mongolia. She has written the books. She has publications in epilepsy issue in Mongolia, and she has been representing the Mongolia. And I remember her meeting a couple of years ago as when she has taken up the lead. I also welcome Professor Stephanie Clark, who is the past president of World Federation of Neurorehabilitation, and she's from Lucerne, Switzerland. So with that, I would, Professor Stephanie Clark has been known to all the Indian neurorehab specialists. She has been to India many times in many parts of the country, and she has been on various board, and she will be actively talking today with us. She has been very kind to accept our invitation to be part of it. I also welcome all the speakers, and we will go one by one. Before I start, may I just have some introduction on why did we took this session? So before I take that lecture, may I request Professor Mandasir to say a few words. Professor Mandasir. Asmita, can you request her to, put her video on and
Yeah.
yes, Professor Mandasir.
Ma'am, can you unmute yourself? Ma'am, please unmute. Hello. Hello.
Hello, I'm here. Hello, I'm here.
Yeah.
Yes, ma'am, we can hear you.
Hello, I'm here. I'm sorry, I have technical problem.
Yeah, we can hear you, madam.
Ma'am, can you unmute?
Hello.
Yes, ma'am. Yes, ma'am.
Please go ahead. Say your introductory comments, please.
Hello. Hello, everyone. Welcome to our session. Please start the course. Professor Nirmal Surya.
Thank you very much. I highly appreciate, and Asmita, I would like to share my slides.
Hello.
Yeah.
Yeah.
I'm not able to share, Asmita.
Sir, now you can share.
Okay.
Yeah. Just try.
How do I share my desktop?
The very first option, the screen.
Just a minute. This slide as background, this one or portion of screen? Okay.
Yeah.
No. Is this can be
Yes.
visible?
Yes, sir. It's visible. You can start.
So I'll just go through the introduction to neuropsychology before all the experts speaks. I may be not the expert in the field, but we have got all the experts here: Dr. Jamna, Dr. Krishna Murthy, Dr. Shantala, Dr. Stephanie Clark, Jwala, and Mohammed Afsar. So apologize to them, but just I wanted to inform you that Indian Federation of Neurorehabilitation has been proud to announce that we have now become the member of World Rehabilitation Alliance, a association of WHO. And this is the course which we have attended a couple of years ago when I was in Mongolia. And I'll just share some of the pictures that this first Mongolian neurorehabilitation meeting was attended by me. Dr. Namjung was there, Dr. Stephanie was there, and many more were there. It was really indeed a pleasure that I was the first Indian neurologist to be there in Mongolia and having the hospitality from Professor Mandashev. Of course, multidisciplinary team is what we are looking at, and the neuropsychologist comes a very, very important role. And the more we are understanding, more we realize that this is the field which need to be explored upon in the future. So that's something which we really need to do on. So clinical neuropsychology is concerned with understanding the relation between brain dysfunction, cognition, emotion, and behavior in everyday life, and rehabilitation of people with cognitive, emotional, and behavior problem arising from brain dysfunction. And you could see that if the cognition is affected or emotion is affected, how it affects the everyday life. So this is one of the symptoms, signs which can happen with the various brain pathology, whether be it the stroke, head injury, or whatever it is, dementia.
Sir, sorry
Yeah.
to disturb you, but sir, your slide is partially seen. The half side of slide is not visible.
Okay. So how do I do that?
Sir,
Just
please.
make it small.
Yeah. Please fit in the screen.
How do I go?
Just zoom in, sir. Not.
Zoom in.
Yeah.
Mm-hmm. Is that better? No.
No, sir. The half slide is cut.
So how do I zoom in? Here, okay. Now?
Yeah. Little bit, sir.
Now?
Yeah, that's perfect.
Perfect? Okay.
Yeah. Please move 2 or 3 slides. We can see if it is the.
Okay.
Yeah, sir. It's perfect. It's perfect.
Okay. So today's program will include about the overview of neuropsychology, understanding brain behavior, cognitive evaluation, cognitive rehabilitation, dementia rehabilitation, and I'm sure it is going to be much more. We'll also present you the IFNR Con, which is going to happen from 13th to 16th April. And I'm sure this will be very, very exciting. This is an hybrid meeting. You all are invited to, take participation. It will be a fantastic meeting. And I'm sure you all will enjoy this. Some of the pictures during the Mongolia. Thank you very much. And I come back to you at the end of the evening. You can write and send your questions, and the moderator and the chairperson will definitely take over. So may I request Abhishek to introduce the first speaker and take it forward, please.
Good morning, everybody. Good morning, everybody. Take Dr. Jamna's slide, please. This first speaker is Jamna Rajeshwaran from NIMHANS. professor at Department of Clinical Psychology, also run the EEG, the feedback lab, also part of Institute of Mental Sciences for Clinical Psychology. Area of interest are EEG feedback training, clinical neuropsychology. He has multiple publications in key journals. Good friend, avid speaker, and researcher. Welcome, Jamna.
Thank you, Dr. Abhishek. At the outset, I wish to thank the IFNR, the organizers, Dr. Surya, Dr. Abhishek, and Dr. Mahathir, for inviting me to be a part of this very important program. I will straight away go to my talk. I'd like to share my screen. Please enable me to share the screen. Yeah. What I would like to do is to start off to give you an overview of neuropsychology. The format is as follows. I will initially talk about what is neuropsychology, and then a little bit about the history. I'm not really going to go in detail about the history for the want of time. And then I will talk about how assessment is very, very important in clinical neuropsychology, not as an assessment in terms of assessment, but the process that is involved during assessment, and how one should not, one should be very careful while doing this assessment, and later on how to interpret with whatever the data that we get and make meaning out of the data and provide it to the treating team as well as use it for the rehabilitation. So if you look at the word neuropsychology, it's derived from the Greek word doctrine of nerves, neurology, and the soul, which is psychology, which is known as the mind and the brain. So if you look at the definition, what we thought was it is the study of brain and behavior. Look at the way it has gone further. It is a molecular and a physiological basis of behavior, which involves the study of brain and neuron function. So what is brain from a neuropsychological perspective? We are not neurologists, we are not neurosurgeons, we are not psychiatrists. So how are we viewing brain? So I would like to put it as, we view it as an abode of mind. Now what is this mind? Mind is nothing but awareness, thinking, and emotion. Now, awareness, yes, it is very, very important to understand what is happening around us and to give meaning to that awareness. We think, yes, this is what I'm here for. For example, all of you are here listening to the lecture, so you're aware that there's something going to happen in this next 1 hour, and so you are also thinking, what is that I'm going to get from this particular talk, and how am I going to use it? And very unique is with every thinking, we also associate, humans associate their emotions. So what is behavior? Behavior is any drive state, goal-directed, purposeful, and appropriately you have to respond to a given stimuli. That's the underlying factor. You should respond to the stimuli appropriately. So this is the mind and the behavior. As I told you, I've already shared the slides, so I won't go into the history. So the term was used by Sir William Osler, and then on many people started using this term of neuropsychology. The only important thing that we need to remember is the World War, which paved way to understand neuropsychology in a much deeper way. And then the work of Broca, where he identified the language area, and after that, the impetus of neuropsychology took up, and it's gone leaps and bounds today to understand what the brain and the structure and how this structure is resulting in a particular function, and how these functions can be identified by the clinical neuropsychologist in order to help the individual to get back to understand their cognitive functions, and also for the rehabilitation to send them back to the gainful employment. So if you look at in India, I would like to talk more from the Indian perspective because carrying out neuropsychological assessment is an art and science. And in India, it is an Herculean task because we have various languages, we have various culture, we have illiterates, we have literates. So to cater to this population, one needs to be aware of all these factors before we start administering the neuropsychological assessment. The neuropsychology in India, otherwise we call father of neuropsychology in India, is Professor C.R. Mukundan, after which Dr. Shobini contributed in a very big way in developing and standardizing all the neuropsychological tests. Then I came in and along with me, after a few years, Dr. Keshav, who's come in, has developed the elderly battery, and now we have Dr. Shantala, who contributes more from cognition and music. So who's a neuropsychologist in India? This has to be very clearly understood because according to the law of the land, where if you look at it, the person who has completed MPhil in clinical psychology recognized by the Rehabilitation Council of India calls themselves a clinical neuropsychologist because neuropsychologist is a part of clinical psychology where assessment and rehabilitation is taught in the course. And then to call themselves a clinical neuropsychologist, they apart from completing their MPhil, they should do their PhD or their fellowship in clinical neuropsychology. So, what is neuropsychology? Yes, all of us say assessment. I would say, please look at it as a process, not just giving the test and taking the scores from the patient and understanding the interpreting the scores in terms of the normative data. That doesn't give any meaning at all. If you look at it, while a particular patient does this particular test in a particular manner, you will start giving meaning to that assessment in a very beautiful way. So neuropsychology, though we say it is an assessment, it should be standardized and which measures cognition and behavior. So what are this? We know that cognition and behavior are the terms which refer to the highest aspect of human function, and what it includes is right from intelligence to attention to all the executive functions, then perception, learning and memory, and language. The whole gamut of it is there. So there are various domains one need to assess. So how is it? A lesion in a particular area doesn't mean that there can be only that particular function can be impaired. No, because there is the network of the brain. If attention is impaired, all the other cognitive tests are also bound to be impaired. Now, I would like to put it as basic cognitive functions and high cognitive functions. Basic cognitive functions are very, very crucial to further cover the other domains of neuropsychological assessment. Now, basic cognitive functions are attention and concentration, comprehension, immediate memory, and orientation and judgment. To some extent, even motivation is included. Now, how do you, for example, you have to start an assessment where a person is moderate to severely, the clinical condition has impacted the brain. Now, when the patient comes to you, we get a referral asking for a neuropsychological assessment. Now, how do we go about it? Is the neuropsychological assessment possible at all in this person? Or how do I understand this person's cognitive, emotional, and behavioral components? So what we do is we look into we divide it into basic cognitive functions and higher cognitive functions. These basic, as I told you, attention, concentration. So in the behavioral observation, we understand how this person attends, what is that. So what we do is a clinical interview. That one question can answer most of the basic cognitive function. That one question could be, what is your name? The very fact that the person answers the question, he's comprehending it, and he's also remembering what you have asked. How do you know the person is attending? Always remember, in clinical neuropsychological assessment, from the time you say hello to the patient, till you terminate your behavioral observation should be there on the patients. So when the patient, you call the patient looks at you with anticipation. Why are you taking me to this room? For what? Because the patient is not prepared that the patient is we are going to do an assessment. So the patient will look at you with anticipation, and that is the first sign that you know that the patient is attentive. And yes, as we know, most of the diseased brain are functionally less efficient. So on this principle, every neural tissue in the brain has a specific function. And we also know that a lesion, a complex functional network engaged in all the psychological functions. So cognitive functions such as learning and memory are very, very complex. I spoke about the basic cognitive function. Once this basic cognitive function is intact, then you move on to the other domains of assessment. So as on date, even in India, we have 23 internationally used tests standardized for both illiterates and literates. So we have normative data for these individuals where we can carry out the assessment and then interpret the test using the normative data. As I told you, this is a specialized field under the clinical psychology, and which deals with assessment and treatment of behavior directly related to the functions of the brain. If you look at its contemporary definition, is strongly influenced by two traditional foci of experiment and theoretical investigation. There are two hypotheses. One is the brain hypothesis and the neuron hypothesis. In the brain hypothesis, the idea is that the brain is the source of behavior. In neuron hypothesis, the idea is that the unit of a brain structure and function is the neuron. So specialty, you must be competent enough to carry out this assessment because, and always remember, clinical neuropsychological assessment cannot be done in a group. It should be individual because how one individual manifests during the test is not the same with another individual. When you give a test, I would like to give a very simple example here. One of the patients who came to us, we did the assessment. It was an assault due to some riot in their village. And this person was, he had a severe head injury. He came to us, we did the assessment. And of course, the patient did the assessment. There was a lot of impairments. But one particular test, the patient did not do it at all. That is the AVLT, auditory verbal learning test, where the patient refused to do. The student came back and told me that he just doesn't want to do, and he climbs up. And I could see there is a lot of emotional attribution to this particular test. And then what we did was we gave him a break. We did not understand why this patient did not want to do this test. So we gave him a break. We did all kinds of things, but the patient refused to do this test. And after that, when I called them and we had an interview with the patient, we realized that there was a word knife in this particular list of words. Now, when we probed into it, he said his brother was killed using a knife. So you can imagine how this emotion clouds cognition. If we hadn't probed, what we would have done, the patient refused to do it, or patient has learning and memory deficits, we would have given it. But because we probed it, and why a clinical psychologist should do this assessment is because they will take care of this particular event and resolve the conflict. Now, we did have few sessions with the patient, but of course, we did not give the ABLT, we gave a parallel test, which is the logical memory. So this is some things that is why I call it a process. It is just not the test that you give. You must understand why this person who has done a difficult test so well has not done a simple test. Is it because he's malingering? Is it because that there was a distraction while he was doing this particular test? All these components should be kept in mind. So, you know, clinical neuropsychology is an interface between psychiatry and neurology, more so today with clinical cognitive neuroscience. So if you look at the branches, clinical neuropsychology, we deal with patients who have lesions in the brain. And the test that we do is nothing less than 2 to 3 hours. And we do a gamut of tests, right from intelligence to other cognitive domains. It is definitely a scientific investigation of brain behavior relationship, not only aiding in diagnosis, aiding in understanding the patient's performance, whether he can go back to the gainful employment, whether he can go back to his education, what is his understanding, and how this can impact his activities of daily living. All this is taken into consideration, and also advising neuropsychological rehabilitation. Whereas behavioral neurology emphasizes upon the conceptual rather than the operational definition of behavior. Individual case is taken, seen in more as a rather than group statistics, and less informal tests are used to understand their current cognitive functions. And it studies the studies in behavioral neurology, they often sample broader aspects of behavior rather than the use of clinical neuropsychology. Of course, there are experimental neuropsychology. I won't go into it in detail, but you know that a lot of work is going on with the normals to understand the patient population. Why a person a person having a particular lesion behaves in a particular manner is understood once we know what is the normal function. Then the role of clinical neuropsychologist is not only to do the assessment, but also to understand their activities and to give enough intervention, tailor-made interventions to these individuals, understanding the cognitive profile. That's a very objective way of understanding what should be given to this person. Is it the attention more impaired? Is it memory that the person is going to complain of? Is it perception? Is it language problem? All this the clinical neuropsychologist understands and draws up a profile and looks at strengths and weaknesses, and based on their strengths and weaknesses, the intervention is tailor-made. So the clinical psychologists also use this assessment to diagnosis, treatment, and rehabilitation of the patient across the lifespan, has from the developmental, neurological, medical, as we know that whenever there is a brain involvement, cognition becomes an integral part of the disease. So wherever today we know psychiatric illness has brain basis, even general medical conditions like MI due to anesthesia, epidural anesthesia, and the general anesthesia. We know general anesthesia has a clouding of the brain, so hence results in cognitive function. Diabetes mellitus, hypothyroidism, all these conditions do have cognitive deficits. So even general medical conditions are included, are referred for neuropsychological assessment. As I told you, we also give a lot of information to the treating team. We know that at least in our hospital, we have there are in any OPD we have almost 700 patients visiting us. So the neurologists have very little time to probe into this cognition, behavior, and emotion. So they refer for clinical psychological assessment. We give enough information what they have not got during their examination. We provide them with this information. It complements with the diagnosis that is made, and also to understand their level of functioning and to give appropriate suggestion to the treating team as well as the patients. And we this is the structure. When a patient comes to us, first and foremost, a detailed clinical interview of the patient. If the patient is able to give you from the patient and from the significant others, to rule out sensory motor deficit, find out what was the pre-morbid level of functioning, because if the person had intellectual developmental disability, then neuropsychological assessment is not possible on these individuals. For the simple reason, our normative scores cannot be compared with the intellectually IDD patients. So find out what was the pre-morbid level of functioning, what was the kind of personality that this person has, because if you look at most of the clinical condition results in personality change also. So you need to get all these things clear and then do a clinical interview, that is to understand the basic cognitive function, and then choose the test, pick and choose the test which is appropriate for the clinical condition, compare it with the normative data. I would say compare both qualitatively and quantitatively. You will have to interpret the data, and that's a skill that we all learn during this particular training in clinical neuropsychology, and then draw up a profile. What are the strengths and weaknesses, and then write up the report. So as I told you, all this needs to be kept in mind. Then what you need to do is history should be obtained both from the patient, from the significant others, as well as from the medical records, because that will also add to the understanding of your neuropsychological assessment, and then go on to look into different tests, how compare intra-test as well as the inter-test. Because many a times, especially in TBI, the lawyers tell the patient not to do the test. But the beauty of neuropsychological assessment is such that the patient does not know which is a simple test and which is a complex test. And there is no set order of administering it, but there is an unsaid order. You can't give learning and memory before you give comprehension. You cannot give a perception test, visual learning and memory before you give a perception test. So there is an unsaid order, but we do it in such a way that the patient does not know which is a difficult test, which is a easy test. And what happens is this is one good measure for malingering also. You will see inter-test and intra-test scattered in patients who malinger also. And so this is very, very important, and that is why you have to pay attention to every bit of the performance that the patient does during this clinical neuropsychological assessment. And you can pick and choose the test, because we do have come up with each of the domains. We have picked and chosen the test, which we have made a battery out of 23 internationally used tests, and the students administer it. And other details which you should keep in mind, because age, education, occupation is a confounding variable. So you need to understand what is how is age impacted, how is education impacting the performance, and how is occupation impacting the performance. Over the years, we have seen that a person who's just completed 10th standard and has a very stimulating job is better than a person who's highly educated. So these are some things which you need to keep in mind while interpreting the protocol. Culture, yes, and that, as I told you, it is a Herculean task in this country to do a neuropsychological assessment because of the cultural variation. Some culture accepts, some say this is a right behavior, but some culture says this is not the right behavior. As a clinical neuropsychologist, who am I to interpret saying that there is a deficit when the culture accepts this kind of a behavior? So all this needs to be kept in mind before you interpret the data. Then the clinical condition, what is it? Is it a degenerative disorder? Is this the particular illness curable? All this needs to be kept. And what is the course and the progress of the disease? Is it declining rapidly? Is the patient showing any kind of an improvement? What are the other medical history that the person had prior to this onset of this neurological illness? And the neuroimaging data. We are, in fact, we have quite a substantial data to say that how neuropsychology is and the MRI are collaborating very beautifully. So that is another thing that we need to keep in mind. We can keep the neuro imaging data genetic. Some of the illness we know it is genetic. So keep the genetic, if they have done any kind of genetic assessment, look into it and incorporate it and understand the person better. And any kind of psychiatric history, family history, all this needs to be kept in mind. And yes, neuropsychological examination is a very important aspect where you look at the mechanism of evaluation of the brain and behavior and establish what is the profile of the individual. So types of neuropsychological assessment tests that one needs to do. One can do an objective test if you think there are some other things other than the cognitive things that is impacting the individual. So you can choose that. And again, I reiterate here, that is why a clinical psychologist should do a neuropsychological assessment. because they will understand this is not to do with more so with the cognition, but other things are impacting the individual. Maybe a job, the person does not have a job, financial implication, all this can have a bearing on the cognition. So do an objective test, do a projective test, because many patients may not come out with their problems. So if you understand that this person has some other kind of problems that he or she is facing, do an objective test and then individual test, which is a neuropsychological test. So and right now we are all following the battery approach, which includes large variety of tests. So one needs to be competent enough to pick up the test, what you have to do in a particular clinical condition. Then hypothesis testing. I would say this is the most important in neuropsychological assessment. With this education, with this age, with this occupation, I think this person may not do this particular test well. Now, that is my hypothesis. I may see that the patient has done it very well. So I reject the hypothesis and accept the hypothesis and say, and I have to attribute a reason why this person has done this particular test well. Is it the test too simple for the person? Is it cognitive reserve? All this I will attribute meaning to what the person has performed and then take those into consideration while interpreting the result. Screening approach where it can be flexible and efficient, driven by a lot of economic factors. Patient cannot come, so I'm just going to do, over a phone, or maybe when the person comes for a follow-up, I do these kind of tests. So you have to keep this back. What is that you're administering? Is it a battery approach, or you're picking and choosing tests from various other psychological tests, and you're making meaning out of those tests, hypothesis testing and screening. So behavioral observation, estimation of the premorbid functioning, and choosing the test. So I'll quickly go over the domains that we examine. Speed is done by motor speed. Attention, focus, divided and sustained attention. We do executive function tests, working memory, fluency, set shifting, planning, and response. I'm not going into details of it. I don't know if Dr. Shantla will be covering all this. Language, what is the comprehension, what is the expressive language, and what is the level of comprehension that the person has. Visual spatial perception, both from the 2-dimension and the 3-dimension, learning and memory. Need be, we do the intelligence test. If we have a doubt that the person's intelligence is compromised, we do the intelligence test. So if you look at the speed and attention, the tests that we use are finger tapping, digit symbol substitution, color traits, and digit vigilance. We have norms for all this. And if you look at the structure that is involved, the premotor, prefrontal, orbitofrontal cortex, and the test domains are motor speed, mental speed, focused attention, and sustained attention. So this is how this is called the finger tapping test, where the person is asked to tap on the knob that is there for required time. That's what I told you. I won't go into the details. This is for motor speed. And mental speed, this is the one where we ask the person to look into the symbols below the letters, below the numbers that is given, and they have to copy the same. The first few boxes are practice, and then the person continues to do it. We look for time and error. This is the focused attention, which is known as the color traits, where we give them, this also measures the set shifting ability. They have to join with the same color. For example, the trial 1 would be 1 to 2, 2 to 3, they can do it. And trial 2 would be, they have to take one color to the other color and then go on to 2. So again, time and error are calculated. Digital vigilance, sustained attention. We ask them to cancel 6 and 9 in this sheet of paper and look at the error and the time that is taken. So the domain that for fluency, we do the phonemic fluency and the category fluency. We ask them, we have also standardized this for sounds in India, ka, pa, ma. So otherwise FAS is used. The patient is asked to generate words in FAS in India because illiterates are there. So we have standardized it as ka, pa, ma, they can generate. So working memory, we have both verbal working memory and visual working memory. NBAC is used and self-order pointing test is also used. So this is the 1 back and 2 back. So all we have planning. Other things are where this is against, we have standardized for our Indian population. This is the Tower of London, trail making test. Then WCST, Wisconsin card sorting test. Again, all these are standardized for our Indian population. Stoop test, token test for comprehension, Stoop test to understand the attention and the personality aspects of the person, and token test is for comprehension and learning and memory. Now, learning and memory, we have both for visual as well as verbal, auditory verbal learning test and complex figure test. So this also gives us the perception, learning, and memory in the visual. Whereas in the verbal, we have several trials. Each trial, 15 words are there, where we ask the person, we read it out at an interval of 1 second, and the person has to recall. There's list speed, which is a new list. Then there is immediate recall, delayed recall, and also the recognition. We do intelligence tests based on the patient's education, age, whether there are hosts of intelligence tests, which we pick and do the intelligence test. So to look at the overview of the test, the frontal functions are motor function, motor speed, motor coordination, attention, sustained attention, focused attention, expressive speech, receptive speech, nominative speech, and narrative speech. Then executive verbal fluency, design fluency, verbal working memory, visual, both visual as well as verbal, planning, set shifting, and then the temporal lobe comprehension, learning and memory, verbal language and memory, which we get. And parietal lobe, we do a lot of focal signs, which for example, agnosia, apraxia, zelexia, agraphia, body schema disciplines, left-right disorientation, and topographical. Then whichever is appropriate, we start doing the focal signs in the individual, and we do Bender-Gestalt tests for visual perception, and we do block design tests for the construction of apraxia for 3 dimension. All the other reading, writing, calculation, all this is carried out with the patient. So why is assessment so important? Because all these tests, the assessment relies on the test. So a test should be sensitive enough to pick up that particular function, which is attributed to a particular structure. So it must be accurate and systematic in order to understand how this person performed on a particular test. So what are the goals of neuropsychological assessment? To establish pathology. Initially, when I did my neuropsychology, it was more for diagnosis only, because that time only stay was there and no other imaging was there. Now aids in establishing the diagnosis, characterize cognitive deficits, and measure change. So as I told you, it gives an objective measure from the what is the range and what is the severity of the problems exhibited by the patient. It uses a standardized procedure which compares across patients and across different laboratories. Because if I do it and if I send it to a next person for a second opinion, you may see a similar kind of a profile if you do the way one needs to administer the test. Assessment establishes which function is paired, that is the strength and the weaknesses. And as clinical neuropsychologists, we are mainly interested in patients with discrete dysfunction. Why is this dysfunction existing in this condition? Which, for example, in a particular clinical condition, we don't expect this function to be impaired. But if it is impaired, what are the reasons that this particular function is also impaired? Is it that the person did? I'll just give you a simple example. One chief secretary was referred for neuropsychological assessment. I did the assessment, and the person did everything very well. Of course, he did not fail in any of those tests because of the initial stage of MCR, mild cognitive impairment, and then only on block design, which measures construction of acts of a 3-dimension, the patient showed impairment, and that is joined. There are 4 blocks where they have to keep it red, white, white, red. So like this, only 5 cards were given, and the patient showed impairment. I was very aghast to see a person with this kind of a background could not do a test like this. So I thought maybe he's fatigued and called him for the next session and we did the assessment. And I know that Dr. Satish Chandra, who's very neuropsychologist, is very close to the, he's the one who referred this case. I can't go back and say that block design is impaired. So I had to do my job of finding out why this particular person is showing impairment in the construction of access for 3-dimension. So I interviewed the wife. Then the wife told me that he does not even have the skill to button his shirt, tie his shoelace, and he doesn't even know to fix a bulb nor make an omelette for himself. I said, why? What was the reason? Because he had 8 orderlies to do all these jobs. His father was an IFS, so he did not pick up this skill at all. So how beautifully the neuropsychological assessment has manifested that the construction of access to 3-dimension, then everything can be place. So one needs to be, what the bottom line is, that one needs to be very perceptive in understanding why this particular deficit is emerging, which is not what is expected of in a particular individual. So there are various other tests internationally used. We are also in the process of developing and standardizing very many tests. Now, recently we have the computerized test, which is called as the Neuron, which should be there in the market very shortly. One of the, it was a dissertation that we did, and it has come out. So people can use this computerized test. Some of the disadvantages of carrying out this neuropsychological assessment is it's very, very time consuming. And if you don't keep these aspects of fatigue, attention deficits in patient, the protocol can be very, will not give you much of an understanding of the patient's cognitive function. So hence you need to give adequate breaks in between to carry out this assessment. Some tests are very redundant, but still we do it. It reduces the flexibility, but I would say you can do it both from the qualitative and the qualitative performance of the patient. And it is always a balancing act between what is optimal and what is the standard testing condition. And we always aim to see the best performance in the patient for looking into the profile, saying that this is adequate, this is not adequate. And standardized administration is necessary for very many tests, which allows the individual differences to be meaningfully interpreted. Interpretation, as I told you, in both science and art, understand a person with the basic 12th standard also can administer this test, looking into the instruction and giving it to the patient. But what is very, very difficult is the interpretation, because you have to keep both brain and the behavior in mind. And from the time you say hello to the patient till the person says goodbye, because many a times the patient may not even open their mouth in during your testing session, but just give them a break and see how beautifully they will converse with their significant others. And this has to be noted, not to belittle the patient or intimidate the patient, but you should understand that the patient is able to talk, is able to do many things. And what is the reason that the patient is not answering your question is what you have to interpret and look at it more from the clinical psychology perspective. So if you look at the interpretation, what first comes to our mind is the score. What is the score the person has and how is it as compared to the normative data? Please don't do that. Interpret it first qualitatively, understand. I would call this an intact function. I would call this a deficit, and then look into the normative data that will add more meaning to your test. Because many a times we get very scanty protocol. Because if it is severe injury or severe problem the patient has, we hardly have very little. We have very little data. So we have to make meaning of the data and provide it to the treating team as well as consider it for rehabilitation. So definitely the scores themselves has very little meaning. So interpreting these scores does not really give much results, but you look at it both from the qualitative and quantitative, it gives a better results. So purpose of neuropsychological assessment is to localize the lesion, especially today in epilepsy. We know that the awake craniotomy is coming up in a big way to localize, lateralize. They wait for our neuropsychological assessment to assist in clinical diagnosis, to understand the strengths and weaknesses for neuropsychological rehabilitation, and also for prognosis, and to determine the individual difference in general intelligence, specific, because though the structure is the same, the function is the same, no two individual function. I can tell you that neuropsychological profile will definitely be not the same because of the nature and the nurture component that is involved in an individual. We know that no two protocols can be same despite the structure and the function being the same. And for vocational, for education, and what are the other aspects that is contributing to the individual. Uses of neuropsychological assessment, it supports in the profile of the clinical diagnosis. Patient returning back to normalcy depends on the confirmation of neuropsychological assessment. Only if our assessment says that there is no deficits, will the education institution take back the individual, even the occupation, where they will take back the individual. And in formulation of neuropsychological rehabilitation, it gives a very good understanding. To monitor the course and outcome, many a times when the patients are admitted, either they deteriorate or they improve in the wards. So there are several referrals made from the treating team to monitor their course and outcome. In such cases, one needs to have parallel tests because the learning effect should not impact the person's performance. So we have the beauty of neuropsychological tests are we do have several parallel tests. And also we should remember that neuropsychological changes occurs before any structural changes, especially in MCI when they come. If you subject them to a neuropsych imaging, it will be normal. But when you do a neuropsychological assessment, you see a lot of functions being compromised. It plays a very important role in deciding the neurosurgical strategies. We know that the neurosurgeons wait for a report to decide how to proceed in their surgery. And in forensic psychology, it is competency to stand trial, to give evidence with regard to their compensation, insurance, especially in TBI, dementia, and even in many of the psychiatric conditions, this plays a very, very important role. And we know that today most of the psychiatric illness is brain-based, and the first line of assessment base refer is for neuropsychological assessment. So even Lazard in 1995 said to give them the psychotherapy, the cognitive function should be intact. So even if you want to do a psychotherapy or counseling in an individual, you must ensure that their cognitive functions are intact and to do the pre-post assessment. Thank you very much for your kind attention. I would like to take questions if there are any.
Thank you, Jamna. Thank you for overview on the neuropsychology, particularly from India. There is one question from Malaysia, and this is Regina, who is an OT, and she asked you that the test involves motor function, like hand function. How do you assess a patient with hemiplegia on the dominant hand? Example, trailing making test, the time taken to finish task surely will be longer on the non-dominant hand. So if you could answer that.
Yeah, if there are issues, weakness in the right hand, and the patient has started using their left hand, we may keep this in mind. But otherwise, we will refrain from giving these kind of tests, which if the patient has used the right hand and is not able to do, because it is not right to interpret when there is a weakness in the right hand and the person is doing. But for a baseline, what you can do is you still can administer, record it, and say treat it with caution, because we do not know how the person is going to improve further. So when they improve and they come back, then again the test can be repeated to see what is the difference from the first assessment to this next assessment. Is there a significant change that the person has shown?
Thank you so very much. I'm sure there will be questions pouring in. There are more than 350 people on board here, as well as in the YouTube all across the world. We move forward, and as I request all of you to kindly keep on sending your question. There's one more question has come. Sai Lakshmi Manjunath, who want to know that criteria for becoming, you already said the importance of that's I think is all right. The Pratibha has asked you, for me, there's a Moya Moya Foundation in India. Yes, there is. The pediatric neurosurgeon, Dr. Bihani, can guide you on that. So we move forward to the next speaker. And the next speaker is my very dear friend, Professor E.S. Krishnamurthy. And can I have his introductory slides? A great philosopher, I would say that the way he has developed a, mind healing and Buddhi clinic, which is perfectly a combination of his personality. So he's the founder of NeuroCris Foundation as well as Buddhi Clinic, past president of International Neuropsychiatric Association. He's an adjunct professor at Manipal University, executive member at Asian Society Against Dementia, and tremendous work on the brain and its healing through the holistic approach. And his father, a great neurologist, great clinical neurologist, and a musician, was a wonderful person and has great affection for me. He has President Medal from Royal College of Psychiatry. So, Professor Krishnamurthy, the topic for you have given is understanding brain behavior relationship. Floor is all yours, Professor ESK.
Thank you, Professor Surya, for a wonderful introduction and for inviting me here. Thank you to Abhishek, and it's wonderful to be among very well-known colleagues. All of us share very common interests. If I might share my screen. My apologies, I have created a small problem for myself. Just give me a moment. Is this visible?
Yes, sir.
Thank you so much. I'm going to try and put this on presentation mode. Okay. Yeah. Okay. So my topic is understanding brain behavior relationships, and I will be coming at this from a behavioral neurology, neuropsychiatry perspective, which Dr. Jamuna outlined when during her talk. In this lecture, I'd like to talk a bit about the prefrontal cortex and neuropsychiatry. I'd like to talk about the frontal lobe and behavior. I'd like to talk about the limbic brain and neuropsychiatry, and how epilepsy can teach us about brain behavior relationships. And so those are the 4 parts of the lecture. And of course, I'm going to try and see if I can bring it all together. Now, this is the famous skull, brain, and tamping rod of Phineas Gage. And you can't have a frontal lobe talk without reference to Phineas Gage, who was a railroad worker in America and in the late 1800s, and who had an injury while at work, a blast injury, where the tamping rod went through his skull like that. And it, of course, it affected his frontal brain tremendously. He was described by Dr. John Harlow as being responsible and socially well adjusted before the accident, but became capricious, vacillating, and impatient of restraint. And of course, it was thought in the beginning that this was a left hemisphere injury, but later analysis has shown that this probably was far more extensive, with white matter disconnection and involvement of the temporal lobe and the amygdala. But Phineas Gage had the archetypal frontal lobe syndrome. Before we get to frontal lobe syndromes, just to discuss what we call mild behavior dysfunction, which is something we see across the lifespan in people who have minor issues, often traumatic, sometimes developmental, sometimes degenerative, sometimes to do with conditions like epilepsy and multiple sclerosis. In mild behavioral dysfunction or MBD, you have a person who has agitation, anxiety, irritability on the one hand, apathy or aspontaneity on the other hand. They can have depression, delusions, and indifference. They can have disinhibition, emotional lability, euphoria, impulsivity. They can have loss of empathy with poor insight, loss of personal hygiene, and they can have eating behavior changes and sleep disorders. Now, you will notice as we go through the talk that these symptoms can be seen in a range of conditions which affect different parts of the brain. But it's quite interesting that the whole spectrum from neurodevelopmental to neurodegenerative and acquired can all have these features present in an individual who is so affected. Going back to the frontal lobe, for many years, the prefrontal cortex was considered the silent lobe with lesions that were thought to cause little neurological deficit. And indeed, it became a favored site for lobotomies for psychiatric disorders as a consequence. The importance of this region became apparent in more recent times, thanks to, of course, imaging. And functional neuroimaging studies have revealed abnormalities that are associated with depression, anhedonia, and also these abnormalities don't necessarily change, but the conditions are treatable. For example, neuromodulation today constantly stimulates the frontal lobe for a range of conditions. Now, when you have a problem in your dorsolateral prefrontal cortex, there's loss of initiative and diminished motivation. There is a flattened affect. There is an outward display of apathy and indifference. There is reduced verbal output and behavioral slowness, clinically characterized as abulia. And of course, abulia or lack of will is somewhat different from the more generalized apathy. But lesions in the dorsolateral prefrontal cortex are also associated with an inability to plan and maintain sequences of goals and actions. So there is a goal neglect that we see. And in a dorsolateral syndrome, therefore, there are executive function deficits, there is perseveration, there is stimulus-bound behavior. For example, if you put your glasses in front of you, the patient will pick it up and put it on, not mindful of the fact that those are your glasses and not his. And then there is, of course, diminished verbal fluency. All these are part of the dorsolateral prefrontal cortex syndrome. This is the brain facing us as you see it. With orbitofrontal cortex syndromes, on the other hand, there's loss of inhibitory and emotional control. There is an inability to function effectively in the social domain. Impulsive risk-taking behavior is one of the hallmarks of orbitofrontal cortex syndromes, and poorly modulated emotional reactions, disinhibition or socially inappropriate behavior, impaired decision-making, a failure to use emotions to guide decision-making, an impaired recognition of emotional expression, deficits in social and moral reasoning, and deficits in emotional empathy. There are quite a few features that we think of as being classic to frontal lobe syndromes that we see in syndromes of the orbitofrontal cortex. So once again, to summarize, there's disinhibition, there's an inappropriate affect, there is impaired judgment, and there is distractibility. With the medial prefrontal cortex, there is a difference between dorsomedial and ventromedial. With dorsomedial, you get emotional instability, inattention, abulia again, and the more severe syndrome of akinetic mutism. With the ventromedial prefrontal cortex, on the other hand, there's disrupted social behavior as well as disruptions of social, emotional, and value-based decision making. Patients with ACC lesions lack the will to move and talk, even though they are capable of both. And as says Damasio, they have abnormal autonomic arousal, says Critchley, and these lead to a loss of motivation. And damage to the ventral cingulate also leads to deficits in emotion and motivation, with depression having been described. So medial prefrontal cortex syndrome, and if you remember the homunculus, you will remember that the legs hang between the hemispheres in the homunculus, and the body is flung out like that. And to remind you, therefore, with medial frontal syndromes, you get apathy, or when extreme abulia, you get mutism, when extreme akinetic mutism. There is a transcortical aphasia that you can see. There is lower extremity weakness, and there is incontinence. So this is an interesting syndrome, which is quite different from the orbitofrontal cortex syndrome. Just a bit to talk about the differences between apathy and abulia. What we do realize is that apathy as a generic term is extremely common. It's described in a number of conditions. It's often confused with depression in clinical practice. Abulia is rather more specific, and it's seen with lesions of the basal ganglia. And indeed, the original paper came from Bhatia and Marsden in Brain, 1994, talking about how patients had reduced spontaneous verbal, motor, cognitive, and emotional behavior in the setting of clear consciousness. You're more likely to see abulia with conditions like Parkinson's disease, progressive supranuclear palsy, and of course, the prefrontal cortex syndromes. Apathy as a term is far more generic. How do prefrontal cortex syndromes differentiate themselves from psychiatric syndromes? In depression, you do get low mood, you get crying spells. A person with apathy or abulia, the mood itself is seemingly unaffected. In depression, there is anhedonia, or an inability to experience emotions. In apathy, what you see more is loss of interest or loss of motivation to act. So my patients with depression who have anhedonia are often perturbed by it. Doctor, I can't experience emotions. That concern is not there in the person with apathy or abulia. And therefore, the person with depression is often distressed by this experience and will be seeking change, whereas the person with apathy or abulia does not really seek change. So when we looked into this many years ago, we brought up what Professor Marsden called the golf test. And he talked about this patient of his with Parkinson's disease who retired to live across a golf course so that he could go and play whenever he felt like it. And what happened to him as his Parkinson's disease progressed is he would sit on his veranda, he would watch the golf course, but he didn't have the get up to go and play. And that, Professor Marsden said, is classic of abulia. I can see something that I find extremely desirable, but I don't have the motivation to go and do it. And we often hear of complaints about people who sit with the television remote in their hand and can't even be bothered to change the channel. And that is very classic of abulia. Here is something that we see quite often with many conditions of the brain, including frontal lobe syndromes. the clinical features of IEED are disinhibition, where there's an emotional incontinence, the person is not able to control his emotions. There is pathological emotionalism, what we call crying without tears, and there is the pseudobulbar affect. It occurs 4 to 6 weeks after any form of brain injury. The baseline tonic emotions are normal. So when the person is talking to you, they seem quite well. But episodic phasic emotions are hair trigger and excessive. And those emotions are triggered off by a normal stimulus. And this is just to illustrate to you how it's seen in ALS, it's seen in MS, multiple sclerosis, it's seen in TBI, it's seen in dementia, it's seen in stroke, just the proportions being variable. So this is something, IEED is something that we often encounter in clinical practice, just like minimal or mild behavior dysfunction that I talked about. Another feature is hypersexual behavior, which can be a particular feature of behavioral variant frontotemporal dementia, which affects the ventromedial frontal and adjacent anterior temporal regions, which specialize in interpersonal behavior. And when compared with Alzheimer's disease, hypersexual behavior is seen to be specifically associated with behavioral variant frontotemporal dementia. And that also is a pathological behavior associated with brain syndromes. Once again, when we look at behavior in prefrontal cortex syndromes versus psychiatric syndromes, let's look at disinhibition. It's seen in the prefrontal cortex syndromes, but it's often out of context and not relevant to the object. Whereas in mania or schizophrenia, it is often in context and can be sometimes very inappropriate. Mood, for example, in prefrontal cortex syndromes, there is no overt change to mood, although you will notice emotional lability. So the person can be happy or sad in an extreme way in one conversation, but it's not a sustained mood change. Whereas in psychiatric syndromes, mood changes are evident and dramatic. Hypersexuality in prefrontal cortex syndromes is often inappropriate and often results in clumsy displays of overtly sexual behavior. For example, an older person in a family making an advance to a younger member of the family of the opposite sex often happens between fathers-in-law and daughters-in-law, for example, in the context of the father-in-law having a prefrontal cortex syndrome. Whereas in psychiatric syndromes, the behavior can vary from somewhat flirtatious, even appropriately so, to overtly lewd and sexual behavior. Emotional incontinence in prefrontal cortex syndromes is often mood incongruent, which means that they have no control over their emotions, and it's got nothing to do with what you're talking about. So it's not in context to the conversation at all. Whereas in psychiatric syndromes, emotional incontinence is often mood congruent. I'm feeling very depressed and therefore I cry and cry and cry during a session, and the crying is out of proportion. Luria had this very interesting hypothesis of 3 functional units of the brain. And he talked about a unit for regulating mental tone and waking mental states. He talked about a unit for receiving and analyzing and storing information. And he talked about a unit for programming, regulation, and verification of activity. And you can see it is your limbic system that he talked about when he talked about regulating tone and mental states. It is your parietal and temporal lobes that he talked about for receiving, analyzing, and storing information. And it is the frontal lobes that he talked about for programming, regulation, and verification of activity. And I'll come back to this in some time because it is a very interesting counterpoint to how we think about behavior in the brain. Having addressed, therefore, the prefrontal cortex, we learned from Phineas Gage We have learned from frontotemporal dementia. We have learned from traumatic brain injury of the frontal cortex that we do see significant behavioral changes, and the behavioral changes with regard to the prefrontal cortex depend also on which part of the cortex has been affected. I hope I have convinced you about that. Let's now talk about the limbic brain and neuropsychiatry. Now, this is how the brain evolved during the course of evolution. So you have a reptilian brain, you have then a paleo-mammalian brain, and then, of course, the neo-mammalian brain that grew over that. And therefore, the brain has grown and evolved over time. Now, we all know of the Papez circuit, and from an anatomical perspective, these are the limbic structures that form the Papez circuit, which is the circuit of human emotion. I'd like to point out to the olfactory bulb and how the olfactory pathways connect directly to your emotional brain. And of course, this is why smell and smell memory are so important to all of us. And this is why, quite like the humble rat, one of the smaller mammals, our mood and emotions is also influenced partly by what we smell. And what we remember is also partly influenced by what we smell. And you can see the very close connections between olfaction and various critical structures like the hippocampus and the amygdala, the seat of emotion. This is to remind you, this is a very lovely image from Professor Leonard Heimer, which reminds us that this is not just a set of anatomical pathways. This is a chemical-rich system, and a range of neurotransmitters operate in the system, and they play a role in the regulation of human emotion. So MacLean said that the history of evolution of the limbic system is the history of evolution of the mammal, while the history of evolution of mammals is the history of evolution of the family. And in a sense, if you think about it, it is this limbic system that has grown into the neo-mammalian system, involving a very complex cortex. Now, there is the concept of the greater limbic system, which apart from the core areas involved in the Papez circuit includes pontine and medullary areas, masses of thin and ultra-thin fibers, which are rich in monoamines and peptides, and many loci from which complex behaviors can be affected. The hippocampus, which if you draw a line through our ears, is a size of a small finger joint right in the middle on either side. It functions as the comparator of a lot of this information. The information can be novel with a stored stimulus. Information can be novel with predicted or expected responses. And there are fragments of patterns with complete patterns. And then there is, of course, the storage of memory. And if you think about how patients present with hippocampal damage, you will realize that the hippocampus stores memory very much in the way that you and I store files in our office. It is chronological. And therefore, very often, for example, in a person, for example, with Alzheimer's disease, what they are losing are the most recent memories. What they retain are the most remote memories. Hippocampal abnormalities are not unique to degenerative disorders. They are also seen in both schizophrenia and in epilepsy. And studies have shown that both neuronal loss and lesions have preceded the psychosis by several years. So in a sense, these structures have the potential to result in very significant psychiatric disorders. The amygdala is a very interesting organ. We'll talk a little bit about it. But when you ablate it, there is an inability to discriminate harmful situations. There is a loss of dominance resulting in taming of the species. and there is an impairment of a primary reinforcing stimulus from establishing itself. When you stimulate the amygdala, you have olfaction stimulated, oral and alimentary automatisms stimulated, vocalizations stimulated, and autonomic discharge stimulated. The amygdala, of course, is essential as a point of contact between our cognitive representations and the emotional significance of those cognitive representations. It's quite well established today as the anatomical seat of human emotion. And here you can see once again how the basal ganglia, the thalamus, and the amygdala are very intimately linked from an anatomical perspective. And today we also have the concept of an extended amygdala, which is a formidable forebrain system which possesses a rather extensive series of connections, allowing it to directly influence neuroendocrine, somatomotor, and autonomic output. So this is an MRI scan segment showing your brain cut in a cortical slice like that. And you can see how the amygdala with its various subnuclei, this image itself is about 10 years old. So we keep discovering subnuclei, how this is such a complex organ. Here's another image which shows you the connections between our sensory systems, the thalamus, and the hypothalamus and the amygdala. And here, what I'd like to point to you is that, vision, hearing, touch, smell, all these do stimulate our emotion. These pathways are obviously regulated through these organs. Other areas of importance include the ventral striatum, which has a dopamine-rich outflow to the basal ganglia and thalamus, and that forms the limbic motor interface, and the nucleus accumbens, which is a transition zone between the extended amygdala and the striatum. It's rich in D3 dopamine receptors, it's rich in somatostatin, CCK, opioids, CRF, and androgen receptors. And therefore, we have these links between the limbic system and the frontal and the prefrontal cortex, the dorsal and the ventral circuits, and these are mediated by chemicals like dopamine. And that's what this diagram tries to emphasize. What Heimer said was the entire continuum formed by the medial shell of the accumbens and the extended amygdala deserves consideration as an interface with motor systems in emotional reactions. And this again is the complexity of the emotional cortex with the complexity of the neuron-rich interface that underlies our limbic system. McLean made this very, very important point that without a co-functioning limbic system, the neocortex lacks the requisite neural substrate for a sense of self, of reality, and the memory of ongoing experience, a feeling of conviction as to what is true and what is false. So in a sense, it is the links between the limbic system and the cortex that give your cortex the ability to decide on the emotional salience of what you're witnessing, what you're participating in, and what you're feeling. And therefore, when someone talks to you about being delusional from a biological perspective, it probably is that disconnection between your emotional centers and the decision-making centers, resulting in your inability being diminished. You're not being able to decide about the salience of the experience, and then you mistake the salience of the experience in some way. So one could start to argue that a delusion, for example, is cognitive rather than something else. I just wanted to show you this beautiful picture, which tells us something else as well. So here's a snake. Here are the eyes looking at the snake. The image is stimulating your visual thalamus. It stimulates, it's read by your visual cortex, which then stimulates the amygdala. The recognition that this is a snake and this is dangerous to me can happen here. But there are direct connections between your visual thalamus and the amygdala, which automatically lead to that fight or flight response. And remember, the complexity of this and the beauty of this, the fight or flight response is not just emotional. Your heart rate goes up, your blood pressure goes up, and there's an outflow of blood to your muscles that help you fight or flee. And that is the autonomic response. And I often try to explain to my patients that, well, this is what happens when you see a snake. But imagine that you perceive a snake in your environment with no snake being there. Obviously, that's when you have a panic attack, which again is an autonomic response. To point out that there are very significant noradrenergic pathways, very significant dopaminergic systems, very significant serotonergic systems, and very significant cholinergic systems in our brain. And all these pathways, if you look at the uniqueness, they all connect your limbic system, your emotional brain, with your prefrontal cortex and with the rest of your cortex as well. And brain behavior relationships, obviously, this is what underlies them. And of course, we all have other cortices that are associated with emotion. There is the prefrontal cortex, the parietal temporal occipital association cortex, and we just saw that when we discussed the snake and the amygdala. And of course, we have the paralimbic association cortices. And if you go back to thinking about Phineas Gage, his brain damage was not just here. His brain damage influenced these pathways. And obviously, therefore, it is not as localization related as we think. The effects of injury can be quite widespread. Now, let's talk a little bit about epilepsy and what we can learn about behavior in epilepsy and through epilepsy. Gustave and later Geschwind described the interictal behavioral syndrome of temporal lobe epilepsy. And they talked about an intensified and labile emotionality. They talked about viscosity, which is orderliness, excessive attention to detail, and persistence. They talked about hyposexuality. Remember, we were talking about hypersexuality when it came to behavioral variant frontotemporal dementia. They talked about hyper-religiosity, and they talked about hypergraphia. And what they said was people with temporal lobe epilepsy of long standing, not everyone, but some went on to develop this personality syndrome that characterized all this. And if you want to read a good popular science description of this, I would recommend you to V.S. Ramachandran. One of the chapters in his Phantoms in the Brain is God and the Limbic System. And it's very interesting to read. He talks about a person and the way the person presented to him in clinic. Now, why does epilepsy influence your behavior? And one of the most interesting explanations came from Baer and Fedio in this paper in 1977, where they said there was increased electrical activity in your temporal lobe. Understandable, you have epilepsy coming from the temporal lobe, and therefore you will have increased electrical activity in your temporal lobe, resulting in an enhanced connection between your sensory input and limbic processing. Now I take you back to that entire picture of the amygdala, the visual thalamus, And you will realize, therefore, that how this enhanced sensory input can result in increased limbic processing. And therefore, they said, and remember what MacLean said, therefore, they said, all your sensory experiences are suffused with emotional coloration, right? And remember what MacLean said, it's your emotion that gives salience to experience. Now, go back and understand, therefore, why a person with temporal lobe epilepsy could have intensified and labile emotionality, viscosity, hyposexuality, religiosity, and hypergraphia. Believe me, these patients exist. I have encountered them in clinic. They are extremely interesting people who teach you about the brain and behavior. Now, Baron-Fedio went on to describe also how left-sided temporal lobe epilepsy and behavior were different from right-sided temporal lobe epilepsy. They said, and they used this questionnaire, which still exists as the neurobehavioral inventory in epilepsy. It's 100 questions, true and false. It's been recategorized and improved by Professor Dietrich Blumer. What Baron-Fedio said is that people with left-sided focus tended to have a greater sense of personal destiny. They had greater philosophical interests, and they had a tendency to think of themselves less well than their relative thought of them. Okay, so they interviewed both the patient and the relative using the same questionnaire, and the relative had a better opinion of the patient with the left-sided lesion than the patient himself or herself had. So the patient was tending to tarnish his own image. On the other hand, people with the right-sided focus tended to be emotional, tended to have periods of elation and sadness. They also tended to polish their own image. In other words, they had a better opinion on about themselves than what the relative had of them. And this interesting left and right side difference in the interictal behavioral syndrome was brought out by Baron-Fedio. Please remember, this does tend to beautifully align itself with right hemisphere and left hemisphere behavioral changes or personality changes or indeed cognition as we tend to understand it. Kraepelin and had described what he called Verstimmungen, mood, anxiety, somatic and psychotic components in people with chronic temporal lobe epilepsy. And this was re-evoked by Blumer, who went on to describe what he called the interictal dysphoric disorder of epilepsy with 8 symptoms: irritability, depressive moods, inertia, insomnia, atypical pains, anxiety, and euphoric modes. I want to draw 2 parallels. One to my description of mild behavioral dysfunction when we started this talk. The second to what many of you in practice may come across, premenstrual dysphoric disorder in women. Very, very similar. In epilepsy, they tend to occur at various intervals. They last from hours to 2 to 3 days. On occasion, they may last longer. There may be baseline symptoms which fluctuate intermittently. And Blumer said that at least 3 symptoms generally coincides with significant disability. Trimble has pointed out that if you look at the mesial temporal lobe in epilepsy itself, it is a syndrome rather than a single symptom or a condition. And he pointed out that in temporal lobe epilepsy, you get simple or complex partial seizures with or without secondary generalization. You get that EEG with a temporal lobe focus, which helps you decide whether it's left or right. There is an MRI that shows pathology in the temporal lobe. Hippocampal atrophy, hippocampal sclerosis are the most commonly described pathologies that we see. There are memory complaints or there is a cognitive impairment in the patient that is assessed and identified. There is this characteristic psychopathology that we talked about, all those behaviors that we talked about, the Gustav-Geschwin syndrome, anxiety, agitation, aggression, psychotic symptoms, the personality features like religiosity, emotional viscosity, hypergraphia, hyposexuality, peculiar ethical concerns, all this accompanies this syndrome. And therefore, you can consider it as a unique syndrome which includes structural changes in the amygdala, and the hippocampus has neuropsychological symptoms. There are seizures. We treat seizures with anti-epileptic drugs. Those cause psychopathology too. Apart from alleviating psychopathology, there are psychotic features, there are personality features, and there are mood and behavior features, what we call the affective somatoform. There's been a lot of MRI volumetric literature, much of it of late coming from the University of Melbourne, but before that came from Queen Square and has come from other parts of the world. What has that shown? When it comes to the limbic system, a smaller hippocampus has been associated with schizophrenia-like psychosis, including psychosis of epilepsy. It's also been associated with unipolar depression. Indeed, the hippocampus as the region of interest for depression is today well established. On the other hand, even with the smaller hippocampus, some people have a relatively preserved amygdala, and a relatively preserved amygdala has been seen in bipolar disorder. It's also been described in psychosis of epilepsy with anxiety. And the anxiety paper, in fact, was written by Professor Satish Chandra when he was at Queen Square at the Raymond Way unit, and we worked together on that paper. And then, of course, there are temporal and extratemporal gray matter and white matter volume loss, which is seen in all forms of psychosis, including the psychosis of epilepsy. So, in a sense, our mesial temporal structures, the hippocampus, the amygdala, the other parts of the limbic system in that area, what Pap has described, have a great role to play in human behavior. I've brought this out in this commentary in JNNP many years ago. I'm going to finish with a story, and it's a brain behavior story. Kumagasu Minakata was a Japanese naturalist. He never acquired a formal graduate degree. He went off on this tour of United States for several years, attended several universities, never completed studying in any one of them. Yet he managed to write hundreds of papers on religion, on folklore, and natural history. And he had about 50 publications in Nature alone. And you can imagine, most people are very proud to have one paper in Nature. He was so successful that with the Emperor of Japan's support, he returned and established the Minakata residence in Wakayama Prefecture. He was intensely spiritual, little bit in the Gestau Geschwind way. He was actively involved in anti-shrine consolidation protests and the nature conservation movement at that time. He was hyposexual. He was a virgin until the age of 41. He was hypergraphic. Remember, people with hypergraphia are not necessarily creative. They write a lot. And he wrote, his letters are well prescribed. He wrote minuscule letters in compact space. And he wrote a tremendous number of articles, very typical of hypergraphia. He was also emotionally viscous, intense, emotional, short-tempered, irritable. Now, why are we talking about Kumagasu Minakata? He had epilepsy, but he also had his brain preserved, and therefore MRI studies done. And what his post-mortem MRI reported by Murai and colleagues in neurology showed was that Kumagasu Minakata had right temporal lobe epilepsy. Okay. I want to remind you of what Baer and Fedio said about the right-sided focus, emotionality, elation and sadness, a tendency to polish one's image is what they said. But we also talked about the hyperreligiosity, the hypergraphia, the enhanced connection between sensory input and limbic processing in epilepsy as being responsible for behavior. So to summarize, memory and emotion are closely linked. Both have genesis in the limbic system, our evolutionary brain. It's what we share with the lower mammals. Our psychomotor impulses as human beings emerge from the limbic system and are mediated through chemical-rich pathways. And I hope I have convinced you about that. The prefrontal cortex and the limbic association areas modulate our expression, both emotional and motor, of the impulses we have. Most of these learnings, and I said to you that I was relying on behavioral neurology and neuropsychiatry to give this talk, have come from neurological dysfunction. Modern psychology, neuroscience, especially imaging studies, are teaching us how normal brains function. And we now know, for example, which part of our brain lights up when we fall in love. And therefore, I'm very certain that as the years progress, we'll learn a lot more about emotions and brain behavior relationships and emotional discontrol. I leave you with perhaps the greatest neuropsychologist of all time, Luria, whose hypothesis on emotional discontrol holds true. What Luria said is, why does a person have emotional discontrol? Either the limbic outflow is so strong that it overwhelms the frontal lobes, or indeed the frontal lobe is so weak that it doesn't control the emotional impulse. And therefore, the brain behavior mechanisms in our brain lie between these two systems. And I take you back to Phineas Gage as I finish. What we found, it was not just a frontal injury, it was a frontolimbic injury that affected Phineas Gage. I hope you found this useful. Thank you so much.
A wonderful, Professor E.S. Krishnamurthy. It was absolutely mesmerizing to, explain how detailed. For us, it looks like a movie, Bollywood movie can be made out of all the stories what you have shown. But extremely important for us to understand that how brain, emotion, behavior functions and what is the neuroanatomy behind that. There is one question for you, and that is, can you explain ACC lesions?
Right. So the anterior cingulate cortex has been implicated in a number of circumstances. And of course, I don't think our understanding is as specific as we would like it to be. One of the challenges we have with the anterior cingulate cortex is that it lights up in so many circumstances. And this is the problem, that when we do functional imaging studies, one of the most common areas that light up is the anterior cingulate. So this, I want to put that little disclaimer first. I'm going to try and take you back to the slide on the ACC. So I think the salience of the anterior cingulate cortex actually lies in this, that this entire continuum formed by the medial shell of the accumbens and the extended amygdala, it deserves consideration as an interface with motor systems in emotional reactions. And I think we need to think of this as a comparator for the limbic outflow to the frontal prefrontal cortices. I hope that's somewhat clear.
Absolutely. There's another question which I think you should also answer, and I will also add on to that. Is the role of clinical psychologists in epilepsy? And I think both of us can really give insight. I would just say that last 12 years, we have a clinical psychologist on every Tuesday free OPD, and a cognitive therapist every week for last 5 years. And I can tell you that when you evaluate each and every patient with epilepsy, you find that 40% of the patient have underlying some sort of a psychogenic problem. Either it is related to the epilepsy or unrelated to epilepsy or related to the drug. So it is very, very important. I think this is something which every neurologist should have if he's running an epilepsy clinic. Over to you, Professor ESK.
Thank you. I think it's invaluable, and I want to draw on 3 points. I think the first, of course, is that neuropsychological evaluation is such an important part of comprehensive epilepsy care. We need to understand in detail the cognitive, emotional, and behavioral challenges that the individual is facing, and many of them with long-standing epilepsy do. The second, of course, we are considering epilepsy surgery in a large number of our patients. And therefore, in order to make decisions on epilepsy surgery, you really cannot do it without the neuropsychologist being involved. And third, as Jamuna Madam said, I think your role doesn't stop in testing. Our role extends to helping people. And many of the programs that we can use, design and use to help a person with cognitive and behavioral problems associated with epilepsy do require inputs from the neuropsychologist. I think what most of us struggle with is not having enough neuropsychologists available in our systems. And I think that's our biggest challenge today. But I think the role is invaluable.
Thank you very much. Thank you very much, Professor E.S. Krishnamurthy. And we move forward to the last lecture before lunch. And may I introduce Dr. Shantala Hegde. Shantala Hegde is additional professor in clinical neuropsychology at NIMHANS, and she is the faculty in charge of music cognition laboratory at the NIMHANS, Bangalore. She has done a lot of projects, a lot of honor and award, and I personally has been associated with her for last nearly 10 years, and her work on music therapy in neurology and neurological disorder is exemplary. So may I request Dr. Shantala Hegde to speak today on cognitive evaluation. Shantala.
Thank you, sir.
I must thank her because she has got a 6-month fellowship to the Boston, and she's in process to travel to the Boston, yet she accepted our request to take this lecture today. Thank you, Shantala.
Thank you, sir. Thank you, everyone, and many thanks to the previous speakers who have set a beautiful stage for me to take it from there. Let me share my screen before I begin my talk for the day. So I hope my screen is visible.
Screen share.
Yeah. Is it visible?
Yeah.
So,
Yes,
so the next half an hour that has been given to me, I'll take you through cognitive evaluation. I understand that we have people in the audience who are students of clinical neuropsychology, and I take this opportunity to give a broad overview. I'm sure half an hour isn't good enough to take you through all the nitty-gritty of the tests per se, but some of the key points, which, as I said, already has been highlighted by the previous speakers, Dr. Jamuna, and also how the complex interaction between the brain and behavior. And we are only seeing that there is so much more to know about brain and how it impacts behavior in its myriads way. So today's talk, I'm going to touch upon neuropsychology and clinical psychology. It may be a repetition of few points. Maybe I thought it might be helpful to the younger students in the audience. Why evaluate neurocognitive functions? Is it important? What is the role? What is it? What is this neurocognitive assessment? What are the goals of assessment? Points to remember as trainees or as clinicians. What are the key points that we ought to remember? And what are the steps involved in this process, in this neurocognitive assessment? Are there different approaches? And brief overview of the test that we often use in our setting here at NIMHANS, and which is also followed in other neuropsychological settings in the country. Of course, as we move on, we will know that the clinician and the neuropsychologist will have the freedom to pick and choose the test based on the needs of the patient population that they are working with. So this has been kind of said well repeatedly in the last 1.5 hours, 2 hours that we have had. Neuropsychology is a super specialized area in the field of psychology itself, and clinical psychology, clinical neuropsychology is a super specialization area. But the bottom line is to understand this complex brain and behavior relationship. So one, cognitive neuropsychology or cognitive neuroscience looks at the normal human brain, and so much more has been understood over the last 2 centuries from localizationist point of view, that very specific areas are attached to or correlated with certain functions like language functions, or certain neurocognitive functions like attention, behavior, range of behavior, the emotion. But also important is when there is an injury to the brain. So as Dr. Jamuna already highlighted, a lot of work kind of surged post-World War. Prior to that, of course, there were localizationist point of view. There were no, fMRI, EEG studies that were done, but it was all based on post-mortem analysis, looking at mapping certain areas of the brain to certain functions. So there is, even today, these branches thrive and they are considered as the frontiers in the field of psychology. Cognitive neuropsychologists, cognitive neuroscientists, and clinical neuropsychologists specifically looking at when there is an injury to the brain, what are the concomitant results that you're looking at in the changes in the behavior, changes in the brain functions, the cognitive functions that we talk about. So even today, it's a multidisciplinary approach. So there is a lot of give and back that happens between these fields. The clinicians, the research that happens in the clinical field goes back to the basic research, looking at how does the normal brain function then? Are we missing out something? Is there something new that we need to know? So we have come a long way from Broca's area, looking at Wernicke's area, or the conduction, the connections, but we are today talking about complex neural networks, both at the higher cortical level, cortical, subcortical level, and even newer studies that are looking at just the brain not doing anything in a resting state. What is the activity that's happening in a resting brain? And does it differ in normals to clinical population or within normal population if they're highly trained, skilled people? Or so, as I said, it's still a long journey ahead, but to understand the complex interactions between brain and behavior. The crux is that it is a multidisciplinary work, and clinical neuropsychology draws this information from basic science, neuroscience, neurophysiology, anatomy, and it's a complex understanding of this brain behavior. And the clinician's role doesn't just end there. So as I said, once there is an injury to the brain, the next question is, how has it impacted? Now, how you need to quantify, because you're not just a clinician, but you're also trying to be a scientist researcher here, looking at quantification, which is very, very important. And then, is it just enough to know to what extent the injury has happened and its impact on the cognitive functions? No. As a clinician, it's important that how do we intervene? How do we help these patients in intervention? So clinical neuropsychology is I would say, is the frontiers in the field of neuropsychology. Now, why study neurocognitive deficits? A lot has been said, but let me highlight this point that cognitive deficits predict everyday functioning. As we know, you cannot do any activity without the brain. Brain is the seat of all this behavior that you observe. And any injury to the brain leads to the neurocognitive deficits. It could be a focal injury to a host of, like a diffused injury, but it could also mean that there is select neurocognitive deficits or a host of neurocognitive deficits. But irrespective of the intensity or the severity of injury, today we know that it does impact everyday functioning. What else does it do? It also determines to what extent there is recovery in these patients. Does the severity of the injury determine the functional recovery? Yes. Does it impact the quality of life? Yes, because you improve neurocognitive functions, it has an impact on their day-to-day functioning, occupational functioning, and in several conditions, not just neurological conditions or neurosurgical conditions, even in neuropsychiatric conditions, we do know that neurocognitive deficits determine relapse, It determines the overall quality of life. It also has a significant bearing on disability. That means how much loss of, contribution that an individual can make back to the society, that we call as DALI, right? Disability assessment of how much does it impact the society. Neurocognitive functions play a very, very important role. And we know now that neurocognitive deficits can predate the onset of certain neuropsychiatric conditions. In fact, even in neurodegenerative conditions such as Parkinson's disease, now studies are showing that even before the onset of tremors, neurocognitive deficits, emotional changes can occur even prior to the onset of the motor symptoms. So it almost seems like the brain gives us a signal that yes, there is an impairment, there is a concomitant or correlating neurocognitive deficits. It plays a very, very central role. It's not as just a part of the symptom, but as a symptom profile itself. Like you would not just say that it is concomitant with other symptoms that you would see, like in motor functions or motor deficits or other seizure deficits. But neurocognitive deficits are standalone in that sense, which have a significant impact in looking at the patient's recovery, patient's relapse rate, and how well the patient responds to intervention as well. So it is extremely important that we do neurocognitive evaluation. Now, as I said, it's not just looking at neurocognitive deficits, but also emotional and other psychological sequelae that occurs. The consequences of these deficits on functional everyday life is also on mobility. It could be on occupational functioning, social role reversals happen. In our clinical setting, often we see that injury to the brain, it could be stroke, it could be epilepsy, it could be head injury. There is a sudden change of role that the patient undergoes. So all this has an impact on the day-to-day functioning, on everyday life. And often we see that emotional changes that occur also in turn have its impact on neurocognitive deficits. So it's a complex interplay between neurocognitive deficits and the individual's overall functioning. And of course, as clinicians, we also look at how it impacts the relationship, the social milieu, and that's where the holistic perspective comes into picture when we are looking at neuropsychological evaluation and neuropsychological intervention. Now, what is neuropsychological assessment? What is it different from when we say just regular evaluation of patient or screening or just psychological assessment of patient? Here, as any clinical psychologist, trained psychologist would use standardized validated tools. It's a procedure to evaluate the behavioral and functional expression of brain dysfunction and to identify to what extent this injury to the brain. Here, I mean both physical injury or functional changes that happen in several neuropsychiatric conditions, that you look at cognitive, sensory, motor, emotional, and even general adaptive capacities of an individual. So it is an overall assessment of the brain function. So it is not that we just look at one small window and then say that, okay, this neurocognitive function is deficit, but you look at the person holistically and you look at all aspects when you carry out the neuropsychological assessments. What are the goals of neuropsychological assessment? One, it has already been mentioned that to detect the brain dysfunction itself. Often we'll see that injury may be very local or very focal, but the neurocognitive deficits may emerge from a host of it, indicating that it is not just a focal injury that determines the neurocognitive deficits, but the interconnections between these areas to other parts of the brain, which may appear ostensibly that it's not injured, but still plays a role in determining the neurocognitive deficits that we see. So one is to localize these neurocognitive deficits, also to lateralize these deficits. Neurocognitive assessment, the findings that we carry out, is very, very important in assisting diagnosis itself, especially degenerative conditions like dementia or differential diagnosis with the severity of the injury, the neurocognitive profile as well. It also helps us, as I said, evaluation of these neurocognitive deficits on daily life. How much does it impact the overall quality of life? How much is it impacting the emotional domains of functioning? So it's very, very important information for us in helping these patients. It also helps us to determine the potential course of the recovery, or sometimes the course of the illness itself. Like in degenerative condition, it may be important to do the evaluation at the beginning or the early stages, and neurocognitive evaluation done at repeated intervals would give us an important insight into how fast the disease is progressing, or is it status quo, or if the intervention is given, how well this intervention is helping the patient. It also helps in often creating a baseline premorbid level of functioning. Of course, because of the complex cultural scenario that we have in India, getting a hardcore, premorbid functioning as in the West, based on verbal content or verbal abilities that the individual has had. Here we do a detailed clinical evaluation, a thorough detailed evaluation with the patient, the caregiver, to get a fair understanding of the patient's premorbid level of functioning. That is helpful when I talk about the approaches in neurocognitive assessment, whether we are looking at idiometric or psychometric. Nevertheless, as a clinician, it's very, very important to have a fair idea of the individual's premorbid level of cognitive functioning, what kind of cognitive reserve the patient may have. Even sometimes you may have an illiterate patient, but you would see that the person has significant cognitive reserve. It also helps in rehabilitation planning in terms of what are the strengths, what are the weaknesses, what the profile tells us, how should we plan this rehabilitation. It could be paper pencil based task, it could be a drill based approach, it could be a computer based approach, it could be neurofeedback training, it could be any form of intervention that you talk about. You cannot plan a rehabilitation program because you need to set certain clear-cut goals of where you're approaching, where you're heading. And neurocognitive evaluation, getting the quantified data, you need to have some idea of how much is the deficit and how much has been the improvement. In this case, neurocognitive evaluation using standardized and validated tools is extremely important. It also helps us give us feedback to the patient themselves and also to the caregivers. Very important here, because in our clinical setting, often we'll see that patient, we get varied kind of scenarios. Sometimes the patient will come and say, I have cognitive deficits, and you administer a battery of tests and you realize that compared to a normative data, let's say based on their age, education, sex, or urban or rural background, and all of these, you may not see that patient has these deficits marking with the normative data. But subjectively, patient may say, no, I have cognitive deficits. In that case, you just cannot ignore, say that, no, you're fine, you can go back. No, we take the patient's perspective extremely seriously, because if the patient is saying, I have cognitive deficit, it means something. Often, it also means that the patient's premorbid level of functioning must be much, much higher. It could be that patient, other psychological issues may be playing a role. This is where the clinician's skills, the experience plays an extremely important role of determining what kind of feedback you would be giving to the patient. Neurocognitive profile helps us also to give feedback to the family members in children, children who go back to their education from a developmental perspective, or in elderly. It may mean in any clinical condition, giving feedback to the primary caregivers is extremely important. It also helps us address the caregiver burden often they see because of neurocognitive deficits that the patient may be expressing, and that has an impact on their day-to-day functioning, like memory lapses. Caregivers may not understand that all this repeated questioning by the patient, irritability, anger, or behavioral changes that are occurring are because of this underlying pathology and underlying neurocognitive deficits. And of course, as I mentioned, it's a frontier area in the field of clinical psychology itself, and research that happens in the clinical area as well as on normal population. There is a lot of giving back that happens, which in turn helps us improve our approach in neurocognitive assessments itself, to improve our understanding of the brain behavior relationship itself. There's a long journey ahead that we are heading towards. What are the key points to remember when you are doing a neurocognitive evaluation? There has to be a clear rationale for investigation. you need to be clear, okay, why is this patient referred to a clinical neuropsychologist? Now, I need to build, Dr. Jamuna did mention about hypothesis formulation. It's a very, very crucial thing. Of course, the clinical acumen adds to your ability to hypothesize much, much accurately. Now, the rationale is important in also helping us determine what kind of test needs to be administered. What should I never miss in this, in this particular patient? Keep in mind the demographic details. It's very, very important when you're interpreting the test findings. So I cannot stress more, and both speakers have highlighted how complex it is, this brain behavior and brain neurocognitive function. As I said, we are talking today about neural networks. We're not just talking about a given area. So when you're doing clinical interpretation of the findings, of sound knowledge of the basic neuroanatomy, the current understanding of all these research that's happening in the area is extremely important. And of course, not to forget your basic clinical skills, where you keep the patient's background, patient's clinical background, demographic details in mind when you're interpreting all these findings. A detailed past, present medical history is extremely important. Dr. Jamuna did mention about other medical conditions. So a patient who's having, let's say, high blood pressure, or is a known case of diabetes, or has other cardiac conditions, all these could have had an impact on the neurocognitive profile. We do know today that patients who have dementia, who have diabetes, type 2 diabetes, are at risk for neurodegenerative condition, or other psychiatric condition, past history of, let's say, depression, schizophrenia, mood disorder, and now having a head injury or other neurological condition can complicate the findings that you're seeing, or can impact the findings that you're seeing on your testing. So you need to keep all these in mind. So a point that I need to drive again and again is a sound clinical training, clinical psychological training is extremely important to keep all these points in mind. Of course, today we have the luxury of, understanding what are the other investigation, what are the findings, EEG or fMRI or MRI or PET scan telling us the findings, because then it becomes a rich understanding of all these, data that you have, or data points that you have, that you could look at your neurocognitive profile and then say, these are the findings, this is how I need to interpret. Of course, this luxury was not available several decades ago for neuropsychologists and clinicians. What are the three main important components, therefore, I would say, is reviewing the medical records and other records. It's very, very important before you set out to say that I'm going to administer tests on this particular patient. A detailed clinical interview with the patient, and often another person, primary caregiver, who knows the patient, who knows the disease progression or the symptom profile, is extremely important. Then comes, of course, careful selection of tests. Of course, in the initial training, in our setting also, we help our students learn all the tests, because it's like learning the keys on a piano before you get to play a music, melody. And so I keep saying this, that you are learning the keys. You need to know the keys first. So you need to hone your skills and be confident in administering these tests. Why? Because these are validated, standardized tests. You just can't say, I know the test, I've read it in the manual, I'll go administer something, you get some results, and then you say, I'll interpret it. No, you'd be making a huge blunder just by saying that I can read it from a textbook and I'll administer these tests on these patients. Because it's available, manual is available, normative data is available. So I don't have to worry about whether I'm trained or untrained person. No, then you are not really doing a detailed neuropsychological evaluation. You may be making a huge blunder, giving wrong interpretation and harming the patient also. Building careful hypothesis and what you're expecting from these findings is very, very important, because you may be administering the same test, okay, on 3 different patients, but how the patient has approached the test, how did the patient go about doing these tests is extremely important. Once one student came and said, Madam, the patient has attention deficit. I said, really? Then when I carefully looked at the performance, I didn't see deficits in attention. Later, when we probed, it's like the patient did not carry their spectacles, patient was not able to see, patient struggled to do the test, and the initial training had not taken this into consideration. It could be as silly as this, where, and as important as this, that you observe how the patient is approaching. In another case, it could be that patient doesn't identify the numbers, or has agnosia, or has other focal signs, and then you are trying to interpret another result. So it is very important you connect what you get from your clinical history, what does your clinical interview say, what hypothesis do you build, and how do you observe and note down every minute details during your testing, and then use that when you're interpreting the results. Now, some of the key points that you must remember when you're doing neuropsychological evaluation or neurocognitive evaluation. The test may seem very simple. What is it? Somewhere they have to mark a symbol, somewhere they have to cancel a few numbers, sometimes images have to identify colors, or they may have to just identify shapes. It may seem like, some child's toys that we are using. Often, this is people who do not know what neurocognitive tests come and tell that, oh, you're going to do some simple tests. No, these may seem as simple tasks, but these are very, very important. And it's important not to tell your patient that, okay, I'm going to administer some simple tests on you. I have seen a very senior person, as in by age, and he was, a Padma Bhushan person who was a pediatrician himself. And his grandson had observed that this patient was giving wrong prescription to his patients. And then they identified that a neurocognitive evaluation is must for this person. And when the senior person came for neuropsychological evaluation, the neurologist took an opportunity to come and introduce and said, so this girl is going to administer, this clinician is going to administer simple tests on you. Do not worry. I was a trainee then. Believe me or not, halfway through the testing, it was a revelation for this patient that I cannot do simple tasks. Remember, he's a pediatrician, a national level recognized person, a highly intellectual person premorbidly, so high average, I would say above average intellectual functioning premorbidly. But then suddenly gets this insight that I can't do these simple tasks. The person said that she's going to administer some simple tasks. This is catastrophic reactions you need to deal with. And I had to give a break and then have a session with the patient before he could resume the neurocognitive evaluation subsequently, and then later the patient was diagnosed as having early phase of dementia. It's very, very important to build good rapport with caregivers and also to help them let go of covering up for patients. Often this happens, initially when you're not trained, that you may have the caregiver, instead of patient answering, the caregiver might fill up and give the answers, or you may experience expressed emotion during testing. That needs to be handled. That's where I'm again reiterating that your basic training in clinical psychology, how you'll handle these sessions, are very, very important. Also, for caregivers, sometimes it's a revelation saying that, oh, I didn't know that this person can't do these tests, and they have, you need to have sessions, psychological psychotherapy sessions or supportive therapy sessions or some brief sessions subsequently with the caregivers as well. Now, it's important that you may rearrange some of the sequence of the test based on sensitivity to the patient's insight performance. But at this point was also highlighted by Dr. Jamuna, I know that just because you can rearrange, because these are battery of tests, you can choose and select, but you can't just do it randomly. You need to have rationale of how you will select these tests, how are you going to order them, how are you going to give those like verbal within visual, or are you going to give simple tests first or complex tests later, some of the basic cognitive functions that you would assess first, and later you would go on to the higher executive function or the higher order tests, and so on and so forth. Remember suitability of tests. Today, I might just give you a brief overview of the tests that we use in our setup in our center at Bengaluru. But in Mongolia, you may be choosing tests that are suitable for your population. So you just do not go on Google search and then you take some tools and then you say, I can just administer it just like that. You need to be sensitive towards how suitable it is to my population. Is it standardized? Should I standardize this? Or can I have a healthy population if it's for a research study? Some of you may be young students who may be using it for your research work. Then can I have a healthy population and then compare it? And so you need to be sensitive towards all of these basic research methods and what do you mean by standardization and validation of these tools before just pick and choose and using it. Language compatibility is extremely important because minute observations are very, very important. What patient says, for example, if you're not familiar with the language and patient has paraphasias, for example, you wouldn't even know that there is some focal sign that you're observing, or patient has aphasia, or patient is expressing something, let's say on AVLT, on a verbal learning memory test, you're giving some list of words, the patient repeatedly uses some other word, but they may be encoding it in a different way, and then what you're recording is different, then your interpretation is different. So one and very careful observation of patient is extremely important. And if you're previously administered and you want to administer it again, be it in your clinical setting or your research setting, parallel forms of the test, should I use it now? Is it okay to use it now? Would there be practice effect? All these are some things that you will have to keep in mind while doing the test. Another key thing, these are again, may seem very obvious, very simple, but these are important before you set out to do neurocognitive assessment. Has the patient slept well in the previous night? The person is groggy, he's not rested well, or person has traveled all the way from a long distance, comes and sits for your testing, he cannot concentrate. It happens to any one of us. And imagine a patient who perhaps has taken some medications in the morning. On top of it, you are doing such demanding neurocognitive testing, your results may be not valid at all. You cannot just hurry up and do the test. Patient has trained to catch up, or patient is in a hurry, or you are in a hurry. No, just that very setting that as a clinician, you're not settled, or the patient is not settled, or you're just administering it for the heck of it or the sake of it, can mar your entire results. So you need to be, as I said, these are all basic clinical skills that comes along. Or patient is hungry, patient has not eaten. You have a child who is crying, who is cranky, who shows tantrums, and the parents may associate with some other behavioral tantrums, and later you'll get to know that child has not eaten at all. And then you cannot do the neuropsychological testing. As I said, hearing aids, eyeglasses, or patients do not take medication. Many a times they think it's like some other test. So you need to psychoeducate the patient before coming for neurocognitive testing. Make sure that they have taken medicines, or many a times patients end up having seizures while we are doing testing, and then we realize that they may not have had their medications which have been prescribed to them. It's also important to note down what medications they have been on, especially in neuropsychiatric conditions. We know that medications can also impact their neurocognitive function. So you have to keep that in mind when you're doing the interpretation. Then, of course, medical records, current illnesses, this is important, and caregiver who can give you valid and reliable information for the history. Make sure your all test materials are intact and in order before administering it. You don't goof up. You don't keep test materials where you've already exposed the materials and you don't get valid scores. As I said, the order in which tests you administer is extremely important. And of course, keep other tools also handy. As we said, as clinicians, we're not just mechanically doing just neurocognitive tests. You are looking at the patient holistically. Is the patient having depression, secondary to the condition or primary to the condition? Was it pre-morbid? Was it current? All these things are extremely important. So you are looking at cognition, emotion, and then the behavior. Now, what are the approaches? So Dr. Krishnamurthy sir already mentioned about Luria and the history, and Dr. Jamuna also mentioned about the history of neuropsychology and how the testing came about. So initially, if you look at Luria, who was from the school of psychoanalytic school, he was a student of Sigmund Freud, interestingly, had a lot of idiometric approach. That means an in-depth understanding of the individual, his or her pre-morbid level of functioning, having a sound knowledge of that, and then interpreting the findings. Of course, the psychometric approach looks at normative data. You compare it, the patient's performance, to a host of, the similar background, education, which we know plays an important role and impacts neurocognitive functions. So both these approaches, a fine balance of both these approaches are important in a clinical setting. Of course, for research, we may rely more on psychometric approach because that gives you interpretable data and to communicate with your peer group in the scientific world. Now, I will not be able to do justice in half an hour to take you through the nitty-gritty of each test, but Just to give you an overview of internationally, there are hosts of neuropsychological tests that are there. Halsted-Drieton battery, Luria, Nebraska. These are the traditional old batteries that are still being used and quite valid. In the UK, Cantab is used, and it's also often used as even as a rehabilitation tool. In India, we have Dr. Mukundan, and in the early, when he set up the neuropsychology lab, as Madam Dr. Jamuna mentioned, he was considered the father of neuropsychology in India. He initially was so much influenced by the Luria, Nebraska approach, and initially went on to get these internationally used tests and adapting to the Indian sitting and looking at it more from the lobe functions, like each lobe, how you would arrange these tests, looking at from an idiometric approach mostly, although some tests do have a psychometric normative data to be interpreted. And then in 2004, we have Dr. Shobhini Rao, who did this humongous work. I think it was a lifetime work, looking at bringing about a host of international use battery, but having Indian normative data for both literates and illiterates. And her student, Bhumika Karin, under the guidance of Shobhini Rao, developed the neuropsychological battery for children. Again, hosts of tests, international use tests, having Indian normative data. And Dr. Keshav and his student Ravikesh Tripathi has come up with the battery for elderly. So it again has indigenously developed some of these tests, which are quite simple compared to the other international use tests, because we are looking at population above 65 here, and which is now being currently used in our geriatric population regularly. Of course, there are other tests from the country. There is PGI memory scale, WMS, which Indian adaptation of intelligence scales. Again, we also look at general intelligence. Dr. Jamuna did highlight in one of her slides how we look at overall general intelligence, often in infants and children, toddlers or children. We may have to do socio-adaptive functioning quite often. Even in elderly, we may look at socio-adaptive functioning, so relevant tools for those. And then WISC, which has now Indian adaptation, we look at progressive matrices. In epilepsy battery, we look at the overall general intelligence before we set out to do a detailed neuropsychological evaluation. So there's a host of tests. Now, Luria, Nebraska is a standardized battery. It has also a version for children. Of course, it takes about 2 to 3 hours, and our NIMHANS battery takes, as I said, 3 to 4 hours, depending on the patient and the number of tests that you use. The whole approach of Luria, Nebraska influenced Dr. Mukundan's battery that it was developed. It consists of 269 items, in fact, and there are 2 forms. And interestingly, it also has a lot of assessments on rhythm, on expressive speech, on pitch, musical functions also that were considered in addition to other basic neurocognitive functions that have been administered, which is uniform across all the tools and scales if you look at it internationally. So the Luria, Nebraska has, of course, heterogeneous items. There is something called as critical level there. The scores gives us a critical level. So each battery, you must be careful to look at how do you interpret those results. Is it percentile score? Is it the raw score? Is it the critical level score? Or is it a quotient? You might get an IQ quotient or an indices. So it's very, very important that you undergo thorough training before you administer any of these tests. So we generally in our setting say do minimum of 40 to 50 assessments, where by then it becomes kind of part of you. And then you start truly getting into the, it's like learning the basics of swimming. And then, swimming without any, it becomes part of your procedural movement. There's a Halsted-Drieton battery, again, for individuals aged above 15. In some of the institutes in the north of India, they use both this Luria, Nebraska and Halsted-Drieton in their setting. But in our NIMHANS setting, we use the NIMHANS neuropsychological battery. I'll come to that. But I thought I'll just give you a broad overview of which are all the tests that are existing if anybody is interested and suitable to your population in Mongolia, which you would like to use. So the Halsted-Drieton battery also has a host of tests looking at motor speed, looking at speech and sound perception, rhythm perception, tactile perception, the category, the conceptual perceptions, and then gives an overall strength and weakness kind of profile for these patients. Now, coming to the Indian setting, we have, as I said, Dr. Mukundan's battery, which was modified Luria, Nebraska's battery, but looking at the lobe perspective. He also developed intervention program, initially the brain function therapy program. Dr. Shobhini Rao was instrumental in developing, bringing about normative data for the internationally used test. That's the battery, 2004 battery. We also have one of her PhD student, Pushpalata, who helped us with, norms for the Wechsler memory scale, which is extremely important. It has about 11 subtests, and which also looks into the different both verbal and visual domains of functioning and delayed memory, which is not existing in the earlier versions of Wechsler memory scale. So we have the WMS3 Indian adaptation modified suitable to our population with percentile scores. So you could easily get a profile and say, does the person have memory deficits? What are the indices of these deficits? And of course, she developed the hospital and home-based neuropsychological rehabilitation. She has been instrumental for many of us in learning and taking this field forward. Dr. Jamuna has worked extensively in promotion of the holistic approach to neuropsychological rehabilitation. A lot of her work, as she mentioned, looked at neuroimaging data, neurofeedback data, and looking at these cognitive profile in various clinical conditions, and has contributed a lot over the years in looking at various clinical conditions and the cognitive profile. Much of is published. So it's important for young students, especially who are interested in this field, to also go back and read what is a neurocognitive profile, what does a neuroimaging say in many of these clinical conditions, which helps you in building hypothesis when you set out to do assessments on these clinical population. And Dr. Keshav, as I said, has developed the elderly battery. He's also developed a retraining program for the elderly called the Agile Mind. The next 10 minutes or so, I'll quickly run through the different tests. Dr. Jamuna has already taken you through those tests. It would be definitely not possible for us to go through everything in great detail, but I'll give you an overview. As I said, it's a host of neuropsychological tests that are used internationally, but we have Indian norms. It has about 19 tests ranging from 16 to 65 years normative data, both literates and illiterates, male and female, which the group has been split age-wise 16 to 30, 31 to 45, 46 to 65. And the scores, raw scores are converted to percentile scores, 15th percentile, looking at Heaton's criteria of 1 SD below the mean, which means in some tests, like in the elderly battery, we have different approach. We look at 1.5 SD, we look at 2 SD. So based on the international consortiums for various clinical conditions, you might want to look at, if I have to define it's MCI or if it's dementia, then you take the call based on your clinical understanding and knowledge. Now, all these tests are basically can be organized in domain-wise, the motor and mental speed, where you have finger tapping test, the digit symbol substitution test from the Wechsler scales, attention, we have the color trails test, the digit vigilance test, the triads test, which looks at divided attention. Under the domain of executive function, you have a host of tests looking at from fluency to working memory, both verbal and visual, planning, concept formation, set shifting ability, response inhibition, learning and memory, verbal comprehension, and visuospatial construction, as well as visual memory, both immediate and delayed memory in both verbal and the visual domain. Now, running through quickly, the finger tapping test was adapted from the spleen and straws, the earlier thing, but the instrument was adapted to Indian setting. We look at 5 trials, both right and left hand separately. We look at how the person is performing across 5 trials. An average score is taken, and norms are available for both literates and illiterates. This is a classic. In fact, in the epilepsy battery, this is one which actually helps us lateralize so easily about within right and left hemispheric involvement. The digit symbol substitution, of course, looks at mental speed. You have symbols. The person has to, write the symbols for the appropriate numbers, and the scores taken, whether the time taken becomes our score, and errors are also noted down clearly. Now, attention is very, very important. It's one of the basic window to the working brain, so to say. So if your attention isn't okay, then your interpretation of other higher cognitive functions is not very strong, or it should be interpreted very cautiously. So you have focused attention, we have color trails where we make sure, of course, the patient has good color recognition, number recognition, and then set out to do this test. You have the simple one where you have the color trail one, where it's a sequence of connecting 1 to 25 numbers in order. In the second one, where you alternate the color along with as you move in serial order with number. Again, time taken is important. The errors that the patient make is also noted down. As I said, what kind of errors the person make is very, very important for one to make a note of. This is the trial that you give to the patient before you set out to do the actual testing. So you make sure that the patient has understood the instructions and how to administer it. Now, digit vigilance test adapted from Lezak from 1995 has 1 to 9 numbers, and the person is asked to cancel these digits 1 and 9, and time taken, the errors made is very, very important. Now, this is where your clinical skills come. I'll just give some example. The tests, maybe we'll have to have like a workshop with some of the key points. Let's say patient has hemi-neglect. Very interestingly, you'll see that patient has canceled only one side of the page. Even on color trail, sometimes you'll see the patient takes a lot of time, but with a patient who has hemi-neglect, they forget to see the numbers that are placed on the neglected visual field. So these are the observation that I say is very, very important. And it's like Guru Shishya Parampara. You work with a trained clinician, you'll get to observe all these and be aware that I need to observe all this. Sometimes you might miss initially. Then the triads test, of course, it has both, a category that the person has to choose one of the odd word that does not belong to the category. Also, it is a graphithisia kind of testing. So the patient, the clinician will write the number on the non-dominant hand, and the patient has to say both the odd word out as well as the number written on their non-dominant hand. Test of executive functions, as I said, fluency, both category and verbal fluency, design fluency. You have the animals cohort test. Dr. Jamuna mentioned that for the Indian languages, we have used the sounds, the consonants, k, p, m, and given 1 minute duration, what's the average score that the person gets? Or animals name test, the added component in the Indian adaptation is an exclusion of certain categories of animals that the person should not give. So it's a very good indication of inhibition as well, along with the fluency. Of course, a sound knowledge of the brain anatomy and cognitive functions, the neural mapping is very, very important to when you interpret it. Is it more frontal involvement that you're talking about? Is it more a temporal involvement are you talking about? The interpretation is not as very simple as you say, this test is for this brain area. No, that doesn't hold good. Of course, design fluency, again, given a 5 minute duration, you ask the person to come up with novel designs. In the there are 2 conditions. Sometimes you give simple designs based on which the person has to come up with novel designs, and completely novel in the second condition. So you have control condition and non-control condition. You also have verbal and back, widely used tests, both in experimental neuropsychology, psychology, and clinical neuropsychology. You have the NBAC 1 and 2 here. In experiments, you may go to 3 back, 4 back, depending on the population you're working with. Here, there are sounds given, consonants given. The person has to tap if the sound comes consecutively in 1 back and alternatively in 2 backs. So it gives us a good understanding of both focused attention itself, as well as working memory. So what kind of error the person makes, how many errors the person makes, is it the hit score and the errors are the same or is it different? These are all very, very crucial points to look into. Visual NBAC, similar. If the dot in the given card appears in the same grid, the person says in NBAC, they have to signal, or in the 2 back, if it comes in alternate way. So this is a very good test of visuospatial working memory. And you have the self-ordered pointing test, again, with words and stimuli coming. The person has to say whether the words repeated in those 12 cards or was it in row-wise, column-wise. And the person should not repeat the words in the words or the numbers given in those 12 cards, given in order of 3 rows and 4 columns. So the person has to point and indicate. So it's a very good test of working memory, of holding information until you finish the test. Tower of London, again, is a widely used test, and we have Indian adaptation of these instruments, as well as the problems that we have 3, 4 moves, 5 moves. And we look at how many within the given time as of 5 minutes is the maximum time to solve a given problem. Before that, if the person has been able to solve with minimum moves, if a 3-move problem is solved within 3 moves, or does the patient take more than that, all this is recorded. Reaction time is recorded. How did the patient understand the instruction? Did they break the rule? How many times did the patient break the rule? All these are important points to be noted along with the final scores that you get on this particular test. WCST is a widely used test for concept formation and set shifting ability. You have a set of 64 cards. Nowadays, you also get computerized cards, shorter version. You have especially you don't have to do entire 64 cards computerized testing that is available. Here, the person has to sort the cards based on the principles, 4 principles based on shape, color, number, and you look at perseveration scores, you look at non-perseverative scores. Is the person able to get the concepts clearly? How does the person takes the feedback when the clinician is giving? All this plays a very, very important role. The scoring for this is quite complex. So initially, students find it very hard to know how do I score these WCST things. Response inhibition, Stroop test. In the Indian adaptation, we have a fairly large card to help patients to be able to easily administer this test. But the original Gold, developed by Gold et al., has both without the meaningful words, it's an X mark, then followed by the naming and then the color naming task. So you have, and the Stroop effect score is basically subtraction of the time taken for naming the color and reading out the words, ignoring the color in which it has been written. It's a classic test of response inhibition. So the Stroop score gives us a very important indication of good control of inhibition. Token test has 36 commands from very simple sentences of touch a circle, touch a yellow square, then touch a large white square, then going on to very complex ones, touching 3 items and talking about the size, talking about the shape. So it's also a very good test of working memory, not only the complex levels, and also to rule out some of the basic perceptual deficits that you might see in patients. So token test is part of this particular battery. You have the auditory verbal learning test adapted to the Indian population. So you look at 5 learning trials, how much did the person learn? What was the long-term retention? You have a percentage score that you get, that over the trials, how much the person was able to learn. What was the effect of the interference? In between, after the 5th trial, you have the list B comes in, and then a delayed recall after 20 minutes to say how much did the person remember from this list. And you have the logical memory test. Logical memory is widely used test, and you can see this in multiple batteries and multiple tests, starting from Binet Kamat's to Wechsler scales to the Indian adaptation of intelligence test to PGI. Wherever you have a lot of memory component, logical memory is a very, very important component. So this has been adapted from the Wechsler memory scale, and the person is asked to remember a paragraph, and the number of facts that the patient is able to give back is what is scored. Now, race complex figure test is a very good test of visuospatial ability and visuoconstructive ability. How does the person goes about with visuospatial planning? Then important key points that you'll see is whether there is ignoring of components, failure to attend to minor components, rotation, or the size, micrographia, macrographia, all these observations, or constructional apraxia itself for the 2D, that's what you will remember. So there is immediate memory component and a delayed memory after 30 minutes that you will observe. Now you also have memory for designs. There are, it's part of the epilepsy battery. Sometimes it's take longer time. So we pick and choose the test that we do in our setting. Now, as I said, it would be unfair not to just touch upon this low battery that Dr. Mukundan developed based on the Luria Nebraska. I'm not going to go in detail, but here the tests that were chosen were organized lobe-wise: the frontal test, the parietal test, the parieto-occipital test, and the temporal test. Again, taken from the internationally used tests and adapted to the Indian population. Its emphasis on, as I said, its emphasis is on idiometric approach, and behavioral observation is very, very important. Having a good sound knowledge of the premorbid functioning is important. So there is a clinical detailed evaluation of attention. Was there distraction? So as Dr. Jamuna mentioned this clearly, and this we keep telling all our students, your neurocognitive assessment begins the moment patient walks into your room or walks into a unit. It's not after you give some paper pencil based task or a computer based task. Your keen observation is very, very important. So in the Mukundan's battery, all these domains are clearly taken in terms of evaluation of attention. Then you have tests for visual search. There is tests for mental set, internationally used tests such as BGT. The BVRT is used for visuospatial construction. There is also tests for kinetic melody, the motor kinetic rhythm part of it, how well the patient is able to tap, tests of good working memory, mental control, delayed response, sentences, mathematical sentences where the person has to solve problem, a good evaluation of left and right parietal lobe involvement when you're talking about calculation abilities or looking at whether the patient has acalculia, different types of acalculia. Then you have tests of fluency tests, the part of the frontal test, the visual spatial planning test. You have the object assembly test, the mazes test, pass-along test, the BGT, and you also look at the changes in the patient's personality. You make a note of all these changes that the person has. Dr. Krishnamurthy also mentioned if there's a frontal involvement or a temporal involvement, what are the kind of personality changes that you might observe from the premorbid level of functioning. Then there are good tests of 3D visual construction block design tests adapted from other Wechsler scales. The object assembly test, which is a little higher on the abstraction, much more than the block design, visual imagery, the position of parts, spatial planning, all this is extremely important part of the battery that we have. BVRT gives us a good indication of immediate visual memory that's part of this battery. Comprehension, so there are a set of sentences which we understand whether good knowledge of comprehension, is it there or not there, aphasias thereby. Of course, see, as I said, one test can give you multiple information. It's just that later, once you hone your skills, you'll be able to make note of, even when I'm giving a comprehension test, I know that patient has aphasia or patient may have agnosia or patient may have other focal signs. You make a note of it, or different the symptoms that you observe in different types of aphasia as well. Then you have the parietal lobe functions tests that are there. You would look at what kind of distortion that occurs, macrographia, micrographia, rotation, neglect, hemi-neglect, if that is there, you would observe. The course block tests that have been taken. And then tests of apraxias, you give instructions, commands, and see if the person has apraxia, what kind of apraxia, is it ideomotor, ideation apraxia, constructional apraxia, or other agnosias. Host of agnosias that you might want to rule out that the person doesn't have. It could be visual object agnosia, prosopagnosia, familiar agnosia for faces, or inattention, astragnosia or tactile agnosia. The subtle differences between these two, that astragnosia is much more basic in terms of involvement of the parietal somatosensory areas, or left-right disorientation, and so on and so forth. Quickly, we do have the WISC we use for children, in addition to the intelligence test. Looking at it more from an intelligence test, we also could interpret for from a neuropsychological perspective, giving a profile. So it has both verbal and performance skills, which we are currently using in our unit quite widely. So it's just a quick run through for the various tests that are existing, the different batteries that are existing. To recapitulate, neurocognitive assessment must be carried out by a trained professional. So you can understand, it's not just the complexity of the test itself. As I said, it's not very simple. It may appear very simple. Also, to hone your neuropsychological assessment skills on the foundation of your basic training in clinical psychology. Otherwise, it's very hard. You will miss out on a lot of clinical observations that might actually be very, very crucial in your interpretation. A sound background in brain anatomy, and definitely current understanding of neurons. So every day you need to read up, catch up with what's the new literature saying. And so training is important. Going through the medical records, having this interaction with neurologists, neurosurgeons, interacting with them, learning from them is very, very crucial. So there's always a give and take. As I said, behavioral observation, recording it verbatim is very, very important. Careful scoring. You make a mistake in scoring, your whole thing collapses. And how do you evaluate consistency? Dr. Jamuna again mentioned, you may have 2-3 tests given in this entire battery, you may see discrepancies. You have to be keen to observe discrepancies. Writing the report, how do you communicate these findings to your other medical colleagues or to the patient? This is another skill that's a crucial part of assessment. And then utilizing this information for further intervention. It could be for rehabilitation, it could be in further clinical evaluation of the patient. So thank you so much. I hope I've been able to do justice with this topic with the given time. Thank you.
Thank you, Shantala. Thank you very much for a wonderful lecture, and we have some couple of questions for you. One is research on impact of sleep issue on human psychology. Can you please put light in this area of your experience, especially on people with non-pathological insomnia?
See, insomnia or any types of sleep disorders, we do know that they do have neurocognitive deficits. And even in normal individuals, as I mentioned in one of the slides, the key points to remember that patient has had some sound sleep before you do neurocognitive assessment. Sometimes very obvious things can impact your neuropsychological findings. I hope this understand the question that they're asking, because that's a whole different field to know about the impact of sleep on the brain, sleep on the neurocognitive profile.
Yeah, sleep disorders are, itself is a very big one-day workshop. There is a sleep 2-day workshop is being organized in Delhi by Professor Manveer Bhatia on 11th and 12th of February. So those who are really interested in sleep disorder should attend that. Obviously, it does causes cognitive disturbance. For brain health, good amount of sleep is equally important. Then there is another question for you is assessment for children below 5 years. Is there?
Yes, you do have different tools. Like for example, progressive matrices, color, you could start from 5 onwards. Planning, but you also must remember some of the frontal functions you will not start before 8, because the prefrontal functions need time. Developmentally, you know that planning may not have been acquired fully before the age of 8. So even in our children battery, we don't give the maze test or the maze test before age of 7. But prior to that, you may want to look at other, like we carry out socio-adaptive functioning, the developmental milestones. So we use tests such as the Vineland Maturity Scale or the Gessel Scale, or you could even use other older tests. We do have norms for that, like a Seguin Form Board. So you look at the age range and then choose the test and interpret it accordingly.
So what are the limitations of current neuropsychological batteries which being used in India?
Limitations. Of course, we need to have more normative data coming through. What Shobhini ma'am did was a huge task. It's a lifetime achievement, I would say, but we do need some more data that has to come over time. And secondly, there are certain tests which we often use. We know the relevance of it, but the challenge is when we come to the verbal domain, the language, the adaptation of those, because we know that we may not have translations for all the languages or dialects in our country. That's the biggest, and that's what I also highlighted with when it comes to Western studies. It's easy for them to evaluate premorbid level of functioning based on verbal scores. But here in India, it becomes a challenge. What test would you use? How would you use it? So a lot of research can happen in developing adaptation of tests, developing indigenous tests, I would say, and developing Indian norms for further usage.
Thank you, Shantala. Jamna, you are there. There are a lot of people have a curiosity, and a lot of people really are interested to do the neuropsychology MPhil. So could you highlight on the institute where the MPhil can be done? Who are the candidates? How do they go about? And then, of course, we'll ask Professor Stephanie Clark, what are the opportunity for people to get training in abroad and particularly in the Switzerland, because there are a lot of openings. So Jamna first.
Thank you. To become a clinical neuropsychologist, firstly, you must get you must complete your MPhil in clinical psychology, which is offered in 44 institutions across the country, which is recognized by the Rehabilitation Council of India. So once you complete MPhil, where you have exposure to various areas under the clinical psychology, then you decide to specialize in neuropsychology. Either now at NIMHANS, we offer 2-year fellowship, 1-year fellowship for 4 candidates. 2 is we give stipend and 2 is payment seat. So you can apply for that and come to NIMHANS and get trained for 1 year. Otherwise, you can do your PhD in clinical neuropsychology and call yourself a clinical neuropsychologist. This is the law of the land, which is being ratified by the Act of Parliament. This is how, and NIMHANS offers also for training for 3 months for MPhil scholars, because clinical neuropsychology training is offered only at NIMHANS, though it started in 1975. Till date, a structured training is offered only at NIMHANS. Supervised training is offered only at NIMHANS. So what happens? The MPhil scholars who get trained elsewhere lack this training, so they come to us. But we offer them for 3 months.
Thank you very much, Professor Stephanie Clark.
Well, thank you very much for the question. There are 2 different aspects. One is research. If you want to do a postdoc or as a stay in a research institution, you have to choose the best one for your field, obviously. And there is no problem with language because everything is in English. That would concern imaging, development of new tests, or even epidemiology in neuropsychology, statistical approaches. Now, where it is tricky is when it has to do with clinical aspects, because you have to choose the language, English-speaking language, if your country speaks English, or you. For instance, in Switzerland, it's a major problem because to learn to do clinical neuropsychology, you have to see patients. And this is possible in Switzerland, but you need to speak the language, which is in French in my hospital, which, well, less than 100 kilometers away is German, and less than 300 kilometers away, it's Italian. And these are huge limitations. Therefore, for clinical aspects, you need to be sure that you can have, with your degrees, access to the patients and see them, because some institutions are at universities without automatic access to patients, and that if you are in a hospital, that you can do examinations in the language which is needed. But I think it's a great, great experience to go somewhere else and to see other things.
Thank you, Professor Stephanie. I think, Jamna, if I'm not incorrect, I think most of the information about the admission, about the course availability is available on your website.
Yes,
so
sir.
people can look at that rather than asking here. So there's another question from Jen Ping Lee. Will the assessment be able to be used in brain injury patient with premorbid psychiatric disorder like schizophrenia? What are the exclusion criteria in using the battery of the test? Jamna, you reply this. We will come back to this in the later part when Zwala is again going to talk about TBI case study. But Jamna, you can reply at this point of time.
First and foremost, you should understand what was the clinical condition prior to the onset of the illness, prior to head injury. Was the patient on medication? Was the positive symptoms treated? Did they have negative symptoms? All this needs to be taken. And if the patient did have some negative symptoms, we know now that even in schizophrenia, they have cognitive deficits. Now, how has this head injury augmented the deficits is what one needs to tease it out. So we keep the premorbid functioning and do the current assessment and say that this is the current. We definitely you cannot tease it out saying that this is because of schizophrenia and this is because of head injury, because you may not get that kind of profile. Now, currently, the deficits in what are the areas that the person is showing deficits needs to be reported. And as we know that even in schizophrenia, I think Dr. Shantala has developed a package for schizophrenia rehabilitation package. We can do the intervention both from the head injury as well as the schizophrenia point. Thank you.
I must compliment and thank all the speakers to be absolutely in the time. We finish at 12 noon dot this session, and we have a break for the lunch for all of you, and we come back 5 minutes before 1 o'clock so that Professor Stephanie Clark can start her lecture on cognitive rehabilitation. And those questions which are not answered just now, I must say that we will definitely take them at 4:30 to 5 during the panel discussion by the expert. The chair for the next session would be Dr. Abhishek Srivastava and Ashima Nehra. So we break here. Asmita, you can put the flyer of IFNR Con and ask people to join back at 12:55.
Yes, sir.
Thank you, everyone, and see you back.
Thank you, sir. Thank you.
Thank you. Thank you.
Shantala, very good. Very good. You complimented